for anybody whosoever is interested in going for an ultrasound diagnostic and therapeutic, both, right? So how I'll be talking, we will be first discussing what exactly is the basics of physics. Then I'll be discussing the knobology with you, how the eco-texture of the various tissues, needling and artifacts. And once I have finished my presentation, everything, whatever I'm going to teach you today, I will be demonstrating everything on the volunteer. We will be talking about the knobs. So just listen to the class carefully. So if you have any problem, you can just unmute yourself and you can ask me in between, right? And please do not unmute yourself unnecessarily, okay? Unless you have any doubt, please keep yourself muted, okay? So when we are talking about the principle, that is the first thing. When we are using an ultrasound machine, we should know what exactly is the principle on which the ultrasound machine it works, okay? So means how the waves they are generated. So if you just look at this slide, okay, the most important thing, I hope you're able to see the cursor which is moving on the screen. So the most important thing in ultrasound is your transducer. Why? Because your transducer has got the piezoelectric crystals, and piezoelectric crystals, they display a very good property. Okay, what exactly is that? Is that they will be able to convert one form of energy to the other. And how it happens? So if I'm applying any pressure to this piezoelectric crystals, it results in the generation of your electrical potentials. And if I am applying electrical potentials to these crystals, that results in the malformation of these crystals. So a mechanical energy gets converted into electrical energy, and the electrical energy gets converted into mechanical energy. Fine. So when your mechanical energy is getting converted into your electrical energy, that is piezoelectric effect. Please mute yourself, Dr. Abu. And when, see, this is how it happens. We get lost where we are teaching if you just unnecessarily, if you unmute yourself. Okay, no worries. So if we are converting the mechanical energy into electrical energy, this is called as piezoelectric effect. And when the electrical energy is getting converted into the mechanical energy, that is reverse piezoelectric or inverse piezoelectric effect. So it is not only the piezoelectric effect which exists in ultrasound, okay, which actually is the principle of ultrasound. We have both, okay. So now once you have understood this, so let's move on to the next slide. So now see, if I have switched on the machine, okay, so what I'm going to do, I'm going to apply the electrical energy, fine, and I have piezoelectric crystal which is present in this transducer. So what this transducer is going to do, you will be having the malformation of this crystals, right? And that is going to generate the sound waves. So what am I doing? I am converting the electrical energy into mechanical energy, fine. And now once the sound waves, they are emitted, you know, they're being emitted from this transducer, this sound wave, they will be traveling the various tissues, okay? And on the basis of the acoustic impedance between the two, they will be getting reflected back to the transducer.
Can get muted, unmuted.
What happened? Any problem? Any problem?
No, continue.
Okay. Sir, it would be nice if they can put up their question in the chat box. If they have any question, is it possible we can mute them? Okay. So when I'm switching on the machine, I'm just giving the electrical energy. I have the piezoelectric crystal which is present in the transducer. So this electrical energy is getting converted into the mechanical energy, and these sound waves, they will be traveling the different tissues, and these tissues will be reflecting them back to the transducer, okay? And then again, I'm going to have malformation of the piezoelectric crystal which is going to present here, and that results in the generation of your electrical potentials, and they are combined to generate this image, okay? So this is reverse. Why? Because electrical energy is getting converted into mechanical energy. And this is the piezoelectric effect. Why? because the mechanical energy is getting converted into the electrical energy. So your transducer is working both as a speaker and as a microphone. Fine. This is one thing which you need to remember. Okay, so let us discuss some of the properties of your ultrasound wave. Means, how are we supposed to describe this sound wave? What are the few things which you should know when we are talking about the sound wave, right? So when we are talking about this sound wave, this ultrasound wave, what exactly is this? This is basically a longitudinal wave. So when I say longitudinal wave, that means this wave is going to travel constantly in one direction, right? And this wave needs to have some particle, okay, some medium through which it can propagate. And how this is going to propagate? You have compressions, you have rarefactions. You have compressions, you have rarefactions, right? So the medium will be, oscillating in right and left direction, and this wave will be moving only in one direction. That's why we say the sound wave is a longitudinal wave, and the particles, they move in both the direction. Fine. So the movement, you have compression, rarefaction, compression, rarefaction. So that is how the sound wave is going to propagate inside the tissues. Fine. Okay. Coming to the wavelength. When I say wavelength means it is the distance which is traveled by the wave during one complete cycle. So when I say one complete cycle, what does that mean? It means from one compression to another compression, or from one rarefaction to another rarefaction. Fine. So that is going to be the wavelength. When I say frequency means what exactly will be the number of vibrations per unit time. So for example, just see here. Okay, so from 1 to 1, this is one wave cycle. From 1 to this peak to this peak, it is 2. And from this to this, it is 3. So 3 wave cycles are there. So frequency of this wave is going to be 3 cycles per second. And velocity, when we say, that is the total distance which is going to travel by this wave during one cycle. If you can remember this, it is fine. If you do not remember this, that is also fine. But what you need to remember here is frequency is inversely proportional to wavelength, because this is the one important clinical application of this equation, which we should always keep in our mind when we are just performing any diagnostic ultrasound. Fine. So when we say frequency, if I'm using a high frequency, according to the formula which we have learned in our previous slide, that frequency is inversely proportional to wavelength. Means if I'm using a high frequency transducer, this transducer, the wave which this transducer will be emitting, I will be able to see the things only with a smaller, only up to a very smaller distance. Means I will be having more amount of compression and rarefaction of this wave within that closed, I should say, distance, right? But if I'm using a probe which is of lower frequency, I will be able to see, because frequency is inversely proportional to wavelength. So I will be able to see the tissues which are located at a deeper aspect, right? So gist of the story is, when we use high frequency transducer, because we are going to have more compression and rarefaction, we will be able to see the superficial structure superbly, right? And when we are using the low frequency transducer, we will be able to see the structure which is lying at a deeper aspect very nicely, right? So high frequency, we are going to use the transducer for superficial structure. Low frequency, we are going to use for the deeper aspect, and the reason lies in this slide, right? So as we say, nothing comes, free, right? So what happens if we are using a high frequency transducer? We will be able to see the two structures which are lying at smaller depth very nicely. But this wave, because is going to get attenuated very nicely, very easily, okay? Means if a person who is running so fast because he wants to complete the race, right? So he's going to get tired very soon. And a person who is just running very slowly, so he is going to conserve the energy, and that with that energy, he will be able to run a longer distance. So high frequency ultrasound waves, they are going to have more attenuation, and low frequency waves, they are going to have less attenuation. Okay. So this is what you need to remember. About frequency, one thing which I would like to tell you, in ultrasound machine, this is the only one thing which we have got a superb command. Means if I have set the frequency at 13 megahertz, there is nothing, it will never change. This probe will be continuously emitting a frequency of 13 megahertz, right? So that is the beauty, that this is the only one thing which we can control, right, in ultrasound. Okay, what is important to us in ultrasound is this echoes. Echoes means, we have learned in our previous slide that ultrasound is generating the sound, pulse wave, is sound wave. And this sound wave is known as, we call them as pulses, okay? And something which is reflecting back from the tissues to the transducer, we call them as echoes. So in most of the textbooks, you will be finding this word as echoes. So echoes means something which is reflecting back from the tissues to the transducer, right? So if I have put this, I have just used this transducer. So this transducer is gonna emit a wave, and some portion of it is gonna get reflected back. So reflected back is echoes. Some of it is gonna get transmitted. Some portion of it is gonna get scattered, and some portion of it is gonna get absorbed as heat. And this is how the intensity of the wave, it gets attenuated when we are using any kind of probe, low, high. So low, that attenuation takes place slowly, but if you are using a high frequency probe, this whole mechanism, it takes place very fast, okay? Now, if we have talked about the reflected echoes, so why tissues, they will just reflect the echoes back to the transducer. So this is the basic mechanism, acoustic impedance. Acoustic impedance means this is the resistance if a wave is traveling inside this tissue, okay? So there will be some amount of resistance which will be offered by this tissue to the sound wave. And that resistance, we call it as acoustic impedance. And it depends on the density and the velocity of the sound wave. What exactly is the importance of it is, supposedly you take bone, okay? Bone has got a very high acoustic impedance. So it will not be allowing the sound wave to pass through it. So most of it will be getting reflected back, right? So the echoes are gonna be more if a acoustic impedance of a structure is gonna be high, right? So that is the clinical implication of knowing this acoustic impedance. So I'll just try to make you understand with this slide, okay? So this is medium 1, this is medium 2. Always remember, when I say echo, it is not that, it is from one tissue. It always takes place at the tissue interface. And when I say tissue interface, it means that is the boundary between two mediums, right? It's like Rajasthan has got a boundary, Haryana has got a boundary. So the reflection is going to take place at the boundary of Rajasthan to Haryana. It is not going to take place from Rajasthan, one echo is going back, from Haryana, one echo is going back. Okay, it is always at the tissue interface. So supposedly this is medium 1, this is medium 2. Now, if the difference between these two medium, the acoustic impedance between these two medium is going to be very high, then what will happen? You are going to have more amount of echoes which will be going back to the transducer. Like supposedly this is 2 and this is 10. So the intensity of the reflected sound wave is going to be 8. Okay. And if it is 3 or if it is 2.5, then the difference in the acoustic impedance comes out to be 0.5. So the reflected echo is going to be of low intensity. So this is important, this is important when we are talking about the echoes. Fine. So that is the importance of knowing this acoustic impedance. These are the acoustic impedance. If you want to remember, it is fine. If not, that is also fine, but just remember one thing, that bone has got the highest acoustic impedance and muscle, it is 1.7, right? Okay. There is something called as refraction. Okay. So that is also a type, that is also, I should say, a thing which results in the loss of beam density. So what exactly is this? You just try to understand, okay? If I want to have a good amount of echoes back to my transducer, one thing is my direction, okay, of the ultrasound beam always needs to be perpendicular, right, to the structure of my interest. This I'll be showing you and I'll be demonstrating you. Just try to understand the concept, okay? My beam needs to be perpendicular so that the angle of incidence is equal to angle of reflection. Like, you know, this is the normal. So if my transducer is in this direction, the reflected echoes are going to be very good. But if supposedly I have not kept my transducer in a way that it should be perpendicular to the structure, but I'm just trying to look it from an oblique angle. So that time what happens, you have the change, you know, because it is this beam, you know, is gonna not get reflected back directly to the transducer. You will be having the loss of the beam intensity, so you will not be able to see the image very clearly. What happens, like if you see, this is the Snell's formula, okay? The velocity, we know that velocity is equal to frequency and wavelength. So what happens, frequency of the transducer remains constant. So what this wave will do, it will try to change its wavelength, okay, so that this side becomes equal to that side. And this is how, that is why it has happened. Now see, the direction of this beam has been changed according to the velocity of the sound wave in these two mediums. So what will happen now, the wave which will be reflecting back to the transducer will not be reaching the transducer, will be just getting lost somewhere, and we will not be able to see the structure properly. So the practical message of this slide is, whenever you are trying to look at the structure, always try to keep your probe perpendicular so that you are going to have a good clarity of your image. And I'll be showing you what exactly happens if you are not keeping it perpendicular. So this is an example, like we are looking at the biceps tendon. In this slide, my probe, the angle was bang on perpendicular, so I'm able to see the biceps tendon properly. But if it is not there, I'm able to see the same structure, which is normal, but it looks abnormal to me because I'm able to see the darkening of the image here, right? So that is also known as anisotropy, and we should be discussing further. So how the things they will look in ultrasound. Just remember one clear funda. If, you know, a structure which is reflecting good amount of echoes back to the transducer, that structure is going to look hyperechoic to you. Hyperechoic means white, because what we are looking in ultrasound, different shades of gray. Okay, with that we are able to distinguish between various structures. So if a structure which has got a high reflectivity, means which is going to reflect the amount of echo which is going back to the transducer, so that structure is going to look hyperechoic to you. But if, you know, some amount of it is getting absorbed, some amount it is getting reflected, so that structure is going to look hypo to you. And if there is no reflection from that structure, so that structure is going to look black to you. Okay, so this is the basics. But as you will keep on seeing the demonstration on the volunteers, by the end of this course, I'm 100% sure you will be able to distinguish between all the structures very, very nicely. Okay, so tips from the physics. What is important for us for a practical purpose is frequency is inversely proportional to wavelength. So if you are using a high frequency probe, we are going to have best axial resolution, less penetration, but more absorption, right? So more attenuation of our sound wave. And second thing, if I'm using a low frequency probe, I will be able to see the structures which are lying at a deeper aspect very nicely. Always apply good amount of transmission gel so that the sound wave can propagate, because what we have learned, that sound wave needs to have a medium to propagate. If you're not going to give a medium to your sound wave, the sound wave is not going to propagate inside the tissue, fine? And we have different reflectability from different tissues. So that was all about the basics. And if you know this much of basics, I think that will be more than sufficient, fine? So coming to the machine now. Every machine has got a off and on button. Okay, so this button is universal. Okay, so whenever you are new to an ultrasound machine, look for this button. Okay, so that is the switch on power button of that machine. Look for this symbol wherever you're looking at the machine. Look for this symbol, and if you press that symbol, you will be able to switch it on or switch it off, right? First thing, we learn step by step. Okay, the second thing, first I have switched on my machine. Second thing is you should select the transducer. Okay, So now we have learned that if we want to look for any superficial structure means if I want to scan my knee, okay, I want to scan my wrist, I want to scan my elbow, I am going to use a linear probe. Okay, and this I'm saying if I'm scanning a normal individual. Okay, so I am going to use a linear probe. But if I want to look at my hip joint, right, if I want to look at my spine, if I want to examine an obese individual, I am going to use the curvy linear probe, right? And supposedly, you know, you are very new, you don't know which probe you have switched it on. If your machine has got a option, you know, that automatically the probe gets open and then, you know, you need to change it. So look at this, you know, look at the image. If you are using a linear probe, it is going to be like a square, right? If you are using a curvy linear probe, it is going to be like a pot. Okay, this I'll be showing you, but just remember, linear probe, it is square. Curvy linear probe, it is going to be like a pot. If you look at the probe, when I say curvy linear, so this is the footprint. Okay, so curvy linear means the footprint is going to be curved. Okay, linear means this is the footprint, so footprint is going to be straight, linear, right? That's why it is called as linear probe or high frequency probe, and this is called as curvy linear probe or low frequency probe. Fine. Now, second thing, every probe has got an aspect marker. Okay, it could be a light, it could be some groove, like my probe has got a light. So GE probe, they have got a groove like thing, which is here, right? So what that groove is, what this aspect marker is going to tell you. See, this is going to tell you how exactly your image is oriented, how exactly your probe is oriented, and you will be able to understand how exactly this image is oriented, right? So I will be telling you what exactly is the importance of this aspect marker when I'll be showing you. So you will be able to understand it better. And always remember, like some aspect marker, they have got a, when you're looking at the image, you will be able to see either a dot, okay, or a logo of the machine. Like my screen, this is the dot, my screen, there is a logo of this machine itself, right? So every machine, whether it is Sono, whether it's Sonosite, whether it is GE, Saudi, any of the machines, they will have, all the machines will have an aspect marker, because that is going to tell us how exactly the image is oriented, okay? And what exactly is the importance of it, I will be showing you practically so that you can have a better understanding of it, right? Okay. So now we have selected a transducer. We have switched on the machine. We have selected the transducer. How are you supposed to hold it? That is the third step, okay? Always try to hold it in this way, okay? With your thumb and these two fingers. These two fingers, they should be resting on the patient, okay? So that you can have a good grip of it, right? Why is it important? Because what happens, you have applied jelly, okay? If you're not doing an intervention, you are just trying to do a scan, right? So you have applied jelly over there. And if you're not going to grip it properly, what will happen? It will keep on, moving here and there. And you will be finding it so difficult to hold it. Okay, so this is the right way to hold it. Please do not hold it like this and do not hold it like this. That is the wrong way. What you can do, how you can learn, holding the transducer is, you take your mobile, okay? You keep your mobile like this and hold it like this. Practice it on your body, okay? When you're holding your mobile, hold it with your thumb and your two fingers, and try to keep it on your body and just try to practice, okay? So once you have practiced with your mobile, it will be very easy when you're just holding the transducer, fine? So that is the important step. Now, when I say axis, okay, most of the time I'll be saying the longitudinal axis, short axis. So you should understand what exactly it means by that. So when we are saying the longitudinal axis means, if this is a carrot, okay? So when I say longitudinal axis, so I'm cutting the structure into this, in this way, right? When I'm saying short axis, I'm cutting the structure into like in this way, fine? So this becomes the long axis, which is parallel to the maximum length of the structure. And this becomes the short axis that is perpendicular to the long axis, fine? So this, you should always remember that whether we are looking at the structure, we are looking at that structure whether in long axis or whether we are looking at that structure in short axis, fine? Okay, So if I'm looking at a structure in a long axis, how that structure is going to look? That structure is going to look tubular. Okay. If I'm looking at that structure in the short axis, that is going to look round. Fine. So that is another way to remember it. Fine. Certain probe maneuvers which you should know. So when I'm saying I'm rotating the probe means I am changing its axis from long to short or from short to long. Means I'm just rotating the probe, changing the axis either from short to long or from long to short. So whenever during demonstration, when I'm saying that I'm rotating the probe, you should understand that now I'm changing the axis of the probe, right? There is something called as sliding the probe. Sliding the probe means you're just trying to move it from one position. You're just trying to move either right, left, or you're just trying to move up, down. That is also in some books. They say it is translating the probe, but they means one and the same thing, right? Okay. Then there is third maneuver, compression. Okay. Compression means applying pressure with your probe. Always remember one thing, that if your structure of interest is the subcutaneous tissue, okay, means you are trying to when I'll be showing you the lower limb nerves, right? So that time we will be looking at our short saphenous vein, great saphenous vein, and we know they are lying there in the subcutaneous tissue plane. So if we are applying too much of pressure and we know our structure of interest, like the sural nerve and the saphenous nerve, they are just lying close to the vein, right? So if my structure of interest is in the subcutaneous plane, and if I'm applying too much of pressure, and when I'm using this vein as my as one of the marker through which I will be just looking at my nerve, then if I'm applying too much of pressure, this vein is going to get collapsed. Okay, I will not be able to look at this very nicely. So always remember, do not apply compression if your structure of interest is in the subcutaneous tissue. And also, do not apply too much of pressure with your probe, because this is going to hurt the patient. Okay, so just hold the probe gently, apply gentle pressure. Okay, and if the patient says, sir, you're pressing it and it's painful, just try to remove the pressure. There is something called as heel toe maneuver. Heel toe maneuver means we take one portion of the probe as heel, another one as toe, right? So if I am pressing from one end and just trying to focus the beam to that structure, right? So that is heel toe maneuver, as it is shown in this picture. See, here I'm pressing, this I have lifted. Now this I'm pressing, this I have lifted. So this is heel to toe maneuver. There is something called as toggling the transducer. I will be using it very often because this is one of my favorite terminology. Okay, so toggling the transducer means I'm just trying to fan it up. If I'm not able to see a structure, I'll just try to see it from different sides, which side my beam is going to be perpendicular to that structure. So that is known as toggling of the transducer. Fine. So now we have switched on the machine, we have selected the transducer. We have just learned how are we supposed to hold the transducer. Everything we have learned about it. The next thing which we should do is we should select the depth. Now, what exactly is the importance of selecting the depth? Supposedly, I'm looking at this structure. Okay, this is my structure of interest. And see, look at my depth. It is 2 centimeters. Okay, depth you will be able to see on one side of the screen, which I'll be showing you where exactly to look for the depth. Okay, and this is basically 1 centimeter. From 1 to 2, you have, it is in between mm, and then 1 centimeter, 2 centimeter, 3 centimeter, 4 centimeter, something like that, right? So if I want to examine this structure with ultrasound and I have set my depth to 2 centimeter, now you see how much of dead space, okay? And if I have to do an intervention with this small structure, it would be very difficult for me, right? So always select the appropriate depth, okay? You should select it, the optimum depth needs to be selected. Supposedly you have selected a depth and your structure is too above, then you can just decrease the depth. Or if your structure is too deep, right, you can just increase the depth. So third step is always select the appropriate depth to examine that particular structure. Fine. Now, fourth thing is gain. How I usually teach in my classes is gain is like, you know, a song which is being played. Okay, you have given the right to either increase the volume or decrease the volume of the speaker, but you don't have the right to change the song. Means if this is the image, you can make this image bright, you can make this image dark, but you cannot change the image if you are changing the gain button. So when we are increasing the gain, there is a, the machine is going to increase the amount of echoes returning to the probe. That's why the image is going to look hyperechoic to you. And if you are decreasing the gain, this is going to reduce the number of echoes which are returning to the transducer. Fine. So always set optimum gain, right? Okay. Now there is something called as TGC. TGC is time gain compensation. So if we are changing the gain button, the whole image we are going to change. We are going to make the whole image look hyperechoic or look hypoechoic, right? But with this feature, TGC, time gain compensation, I will be able to make the structure hyper or hypo at a particular depth. Like suppose I'm looking at a structure, okay, everything is like looking very good to me, but approximately at a depth of 5 centimeters, my structure of interest lies, and I'm not able to see that particular very nicely. So that time you can use this TGC to visualize that structure nicely. Fine. So that is the function of using this TGC when we are looking at any structure. Then there is something called as focus button. Okay. Some machines they have, some machines they do not have. So if you are privileged to have this button, so what you need to do, suppose your target is at 4 centimeters. Okay. So you set your focal button at that centimeter. What will happen? This is going to converge all the beam from the ultrasound to that particular point. So you will be able to see your target structure very nicely. Fine. Okay. Then the color Doppler. Color Doppler works on this BART principle, blue away, red towards. So I've just tried to make it very simple for you so that you should be able to understand it. See, this is the transducer. Okay, as we have learned, like if we are standing between the two in the platform where one train is coming towards us and one train which is going away from us. So the train which is coming towards us, we will be able to hear the sound of the train nicely. And if the train is going away from us, we will not be able to hear the sound nicely. So this color Doppler also works on the same principle. So this is the stationary source. This will be emitting a frequency. Okay. So the blood vessels, the cells which are moving inside the blood, so they will be reflecting back this whatever is being emitted from the transducer, they will be reflecting back to the transducer. Fine. So if one which is going away, okay, so that will be the reflected wave, the wave which is going back to the transducer will be of lower frequency. And if this structure is moving towards the transducer, okay, so the reflected wave will be of a higher frequency. And this change in frequency, we call it as color Doppler, okay? And this is the formula. If you want to remember it, it's fine. Otherwise, I will be telling you one more way to reconfirm whether you are looking at an artery or whether you are looking at a vein, okay? So we will be discussing in our subsequent slides. Then there is a freeze button, which you will be just using to freeze the image. And there is also a measure button, which you will be using if you want to measure something. Okay, if you want to measure the distance from your skin to your target structure, you can use this button. Few things, how to get the optimum image. Okay, one thing, whenever you want to do any intervention, always remember, like supposedly this is the structure of my interest, I would like to go for an intervention for this structure. And if I have just kept this structure just adjacent to the, I should say, very too far away from the middle of the screen, then I will be finding it very difficult to go about for doing an intervention in this structure, right? So always, gist of the story is whenever you want to see, whenever you are looking at a structure of your interest, always try to keep it in the middle of the screen. It should not be On the right side, it should not be on the left side. It should be in this, on the in the center of the screen. So that is how you will be able to perform a very good intervention of that particular structure. So summary from the machine is, we will power on the machine, we will select the transducer, we will select the depth, we will adjust the gain, we will adjust focus, and if we want to look at the some blood vessels, we are gonna put the color Doppler button on. Fine. Now, how do I look in ultrasound? Skin. Okay, remember this, skin is always hyperechoic because full of connective tissue. Fine. When you're looking at the subcutaneous tissue is, you're having the fat globules, as you can see in this picture, and then you have the connective tissue septations. So connective tissue septations, connective tissue in ultrasound is going to look hyperechoic. Fat globules, they are going to look hypoechoic. So if you want to look at your subcutaneous tissue plane, the subcutaneous tissue plane will always be hypoechoic with hyperechoic septations. Okay, that hypoechoic part is going to be your fat globules, and this hyperechoic part is going to be your connective tissue septations. Fine. Okay. How the muscles and tendon will look like. So muscle, everybody knows that, you have muscle fibers. Now they combine to form the fascicles, and many fascicles, then they form the whole of your muscle. So what you need to remember here is this fibers, okay, the covering is endomysium. So this is the fiber, one covering is endomysium. Many fibers, they have combined, the fibers they have combined to form the fascicles. So this covering is peri, and now many fascicles are there, and this covering is epimysium. In ultrasound, you will be able to see the epimysium, you will be able to see the perimysium, right? But you will not be able to see the endomysium until unless you are using a very high frequency probe, you will not be able to see this, right? So mostly for all the clinical examination, you will be able to see these two structures very nicely. So remember, epimysium is the outermost covering, right? So that you will be able to see. Perimysium, which is going to be inside, you will be able to see. Fascicles, again, they are going to look hypoechoic, okay? So this is how the muscle will look like, okay, in ultrasound. So this is the better picture, okay? So see, you have this muscle, this white, which you are able to see, they are all your perimysium. Now this black thing which you are able to see, this is your fascicles, right? So, and this is your epimysium, okay? This is your hyperechoic, this is your epimysium. So epimysium, you will be able to see. Perimysium, you will be able to see. Fascicles, you will be able to see. Fine. So that is how the muscle will look. Subcutaneous tissue also hypoechoic with hyperechoic. Muscles also hypoechoic with hyperechoic. Fine. Okay, so moving to the next, tendon. Always remember, tendon, they have a sheath, okay? So sheath means they have a parietal layer, they have a visceral layer. And within these two layers, you are gonna have the synovial fluid. So the tendons, they have got this sheath because if they have to pass through some of the bony things, so this is gonna prevent the friction between the tendon and the bone, right? There is one tendon, Achilles tendon. It doesn't have a sheath, but they have paratenon. You will be finding this term when I'll be taking your ankle class. I'll be talking about paratenon. So that time you should remember what I have told you today is paratenon is not like a sheath, but it is just a loose areolar tissue which is around the tendon. Why? It is because Achilles tendon is a straight one, right? So that's why you have just a covering of loose areolar tissue around the Achilles tendon. Rest, like biceps, they have a sheath, right? So whichever tendon you take, most of the tendons, when they have to go across the bony thing, they have a sheath. And if there is some pathology, you will be able to see the fluid within this sheath, right? And this Achilles tendon, it doesn't have a sheath, but there is something paratenon, which is just a loose areolar tissue covering, which is there around this tendon, which is gonna nourish the tendon. Fine. Okay. So this is how the tendon is gonna look like in the long axis. Again, tendons are always hyperechoic and fibrillar. Okay. So this is how they look like in the short axis. or sorry, in the long axis, and this is how they look like in the short axis. What you need to remember, short axis, how you can remember, when you look at your toothbrush, right? You're brushing in the morning, you look at your toothbrush tomorrow morning, and the bristles, the topmost bristles, they are going to look like the short axis of the tendon. So that is how you can remember them more, right? So tendon, long axis, short axis, tendon is hyperechoic with fibrillar pattern. This is nerve. Nerve, again, the same covering which we had for the muscle, the same we are going to have the nerve, right? So nerve is again going to have endoneurium, you are going to have perineurium, you are going to have epineurium, right? And how the nerve is going to look like? It looks like a honeycomb in the short axis. We will be showing you this nerve. I'll be showing you this nerve today. So just have this picture in your mind. So the nerves look like a honeycomb pattern. These are black thing are your fascicles, and that is the covering around your fascicles. The whole is your epineurium, right? And this is the nerve in the long axis. This is how it looks like in the long axis. This is how it looks like in the short axis, okay? Blood vessels. Remember one thing, that if it's an artery, both of them, they are going to be anechoic, okay? So, but if it's an artery, the wall is going to be thick, means the white area around this will be a little bit thicker as compared to the vein. Now this artery is going to be pulsatile. You will be able to see as if some pulse, something which is protruding from this black thing. And if you're trying to compress it with the probe, it will not get compressed, okay? And the opposite is for vein. Vein, there won't be any pulsatile activity in the vein. And when you will try to compress it with the probe, you will be able to compress it. So first, just look at, when you're putting a probe, look at this, whether it is pulsatile, or whether then if you're able to find it pulsatile, just try to compress it with the probe. If you're able to do so, if it is not pulsatile, and if you're able to compress it with your probe, then this is going to be a vein. This is not an artery. But if you are able to see the pulsations, okay, pulsatile movement, and if you're not able to compress it with the probe, then this is most likely to be an artery, right? Bone cortex is always hyperechoic, okay? And bone will be casting an acoustic shadow, because we have learned that the acoustic impedance is very high. It won't be allowing the sound wave to travel through it. So whatever comes to the bone, it is going to get reflected back to the transducer. So the propagated signal is going to be very weak. You won't be able to see anything beneath the bone. Only the cortex you will be able to see of the bone, and that is hyperechoic, right? Cartilage, if it's an hyaline cartilage, okay, see, this is an hyaline cartilage, okay? So hyaline cartilage will always be homogeneous hypoechoic thing, okay? And this cartilage will always be present between the bone, right? So this is hyaline cartilage, how it looks like, and this is fibrocartilage, how it looks like. Like fibrocartilage is again hyperechoic, okay? Because fibrous, more of the fibrous tissue is there. When we are talking about the hyaline, more of the water is there, right? So hyaline will appear homogeneously hypoechoic, and fibrocartilage will appear hyperechoic. You will be seeing this when we will be fibrocartilage, when we'll be showing you the shoulder, you will be able to see it when we will be showing you the knee. Hypoechoic, you will be able to see when we will be showing you the elbow, in fact, the shoulder, right? So we will be showing you this, but just remember how they look like, right? Ligament, always remember that ligament is from one bone to another bone. So if you are able to see one hyperechoic fibrillar thing between the two bones, most of the time, this is going to be a ligament, right? Okay. Bursa, until and unless they are enlarged, you will not be able to see them, with ultrasound. Until unless you have the fluid which is inside them, then only you will be able to see them. Now, supposedly, so that was all about the machine. That was all about how the various structures they look like. Now you want to go for a procedure of this patient, okay? So what exactly are the things which you should keep in your mind is, I have framed this mnemonic, that is brain, okay? This is very easy for you to remember. Always explain the benefits of doing a procedure to the patient. Always explain the risk associated with it. Any other alternative procedure, like if I want to go for a tenotomy of my common flexor tendon, I can just give an alternative to the patient that yes, I have PRP, or I have PRP, I have dextrose, I can give only the normal saline. So you just tell me which option you would like to go for. So always give an alternative to the patient. Obtain an informed consent from the patient. And once you have taken the patient inside the OT, always remember this POM. So these are the two mnemonics which you should always keep in your mind when you are performing any procedure, right? POM is, see, when you are doing a procedure, there should be the ergonomics should be very good. You know, the position of the patient, the position of the machine, and the position of yourself. Okay, you should not be looking at the machine like this because you'll be straining your neck muscles. So that is also very important. Okay, you can see this in this picture. So if see the way she is scanning, even the patient is not happy and she is also not happy, but now both of them, they are happy. And if she's performing a procedure, see how much of neck, you know, she needs to extend in order to look at the USG machine. So this, all of the things, they plays a very important role in performing, in scanning, in performing an intervention or scanning any of the ultrasound things. Okay, so we should not be ignoring them as well. Coming to the needling, usually we use this 22 gauge spinocane to do most of the procedures. And for the superficial, we just go for the needle which is attached to a 5 ml syringe or the 2 ml syringe. Okay. Needling, one thing is important, the gauze of the needle. Okay, we can just perform everything with this. I think I have the needle. So that is a 22 gauze needle. I'll be showing you again. So you can perform most of the procedure with this. Okay. But you can just take, you know, a higher gauge also. There are papers where people, they have gone for 16 gauze, 18 gauze, the epidural needle. Okay, but what will happen? You will be causing more trauma to the patient. You will be able to visualize the needle properly, but at the same time, you will be causing more amount of trauma to the patient. So for MSK purposes, 22 gauze needle is more than sufficient to perform all the procedures. Okay. Now, the echogenic needles are there in the market, so you should also be knowing about them. Echogenic means you will be able to see the whole needle properly. But what I believe in, if your ergonomics are proper, if your position of the probe is, you know, very nice, until and it's a very difficult patient to scan, most of the time your needle will be bang on. Okay. So these are echogenic needles to make our intervention more easier. Okay, now there are two ways to go for an intervention. Either you can go in plane. In plane, when I say, I will be able to see the whole shaft very nicely. So that is in plane. When I'm saying I'm going out of plane means I will be able to see only a fraction of my needle. I will not be able to see the whole needle properly, and this will always be from the mid of the probe. Okay, so that is out of plane. This is in plane, right? Now, when I'm going out of the plane, what exactly is the drawback is I will be able to see only a fraction. So if my needle is somewhere here, I will be able to see. If my needle has surpassed this, I will be able to see. So this is the drawback with out of plane needle technique. As all of you are just beginning, according to me, I don't know how many of you are really practicing ultrasound, but those who are just learning the ultrasound for the first time, I would request all of you to go for in-plane technique in your initial aspects of doing your ultrasound procedure. Please do not go for out of plane technique because this is very dangerous, okay? And you might be just ending up in some bigger complications, which is gonna dishearten you so much, right? And so always go for in-plane whenever it is possible for you, right? Second thing, whenever you are just trying to put your needle inside, make sure the bevel of your needle is up, okay? And when you have just reached that structure, turn the bevel down. What is the clinical, practical, tip from this is, if our bevel is up, okay, now you see, because there will be a difference in the shaft and the bevel. So I will be able to see this needle tip nicely. But see, if I have turned it upside down and if I'm trying to go inside, this hole will appear as a white line to me. Okay, so always whenever you are trying to go for any intervention, because you can see in this picture, okay, this is straight and then you have a dip. So the reflected wave, there will be a difference from this surface or from this surface. And this difference is surely going to help you when you are going for any procedure. Always keep the bevel up when you are moving your needle inside the patient's inside the patient. Okay. Tips for the better visualization of the needle. Supposedly you have put the needle, you are not able to see. What you can do, you can just take the needle up, down, so that you will be able to see the movement there, right? Or you can do is like you can pass a stillet through it. Okay. You can just dip the needle in water, and then if you put the needle inside, so you will be able to have a better visualization. Sometimes what you can do is you can switch on the power Doppler, okay, and you can just move your needle. So Doppler will be just sensing the movement, right? So Doppler is going to tell you where exactly your needle is. And finally, you can just use small aliquots of normal saline and just do a hydrolocalization just to find out where exactly your needle is. Anybody who is interested in practicing for the needle, the easiest one is just go to any grocery shop, buy one tofu or paneer. Okay. If you're having an access to the ultrasound machine, take your probe, take one needle and try to practice the needling in that tofu. Okay. I learned in that way. Okay. When I think 6 years down the lane, when I started this ultrasound, this tofu has really helped me a lot. So I always say to my participants that please go and practice needling first, because see, if you are doing anything wrong in this tofu, we are not harming anything, right? We are not harming anybody. But if you are doing some procedure inside the patient, our direction is not proper, then we might end up in some complication which we don't want to do, right? So practice needling at least very nicely before just putting a needle inside a patient's body. Some artifacts which we will be talking very often, anisotropy is one among them. So anisotropy, I have already shared with you before that if your beam is not perpendicular, then you will be not able to see that structure properly, and that structure is going to appear darker to you. There'll be a loss of image resolution. Fine, this is what has happened here. So that is the biceps, this is the Achilles tendon. So you will be knowing it more when we will be demonstrating, but just remember this is an artifact, and just try to toggle your probe. This artifact will go off, because as soon as your beam is going to be perpendicular, if you're looking at the structure and the structure is appearing like this, just try to do heel toe maneuver, try to toggle your probe. Then if there is no pathology inside this tendon, this is going to look like this, right? So that is anisotropy. Second thing, always apply good amount of gel, because we have already learned that sound waves, they want some medium to propagate. So if you are not giving them a medium, the sound wave is not going to get propagated and you are going to get an image like this. Okay. Third thing is posterior acoustic shadowing. We have already learned that if there is bone, okay, there is some calcification, okay, inside any tendon or anything, we will not be able to see beneath that, okay, because everything will come and will get reflected back to the transducer. So posterior acoustic shadowing means there will be a hyperechoic line, and beneath that hyperechoic line, you will not be able to see anything. So that is known as posterior acoustic shadowing, okay. Posterior acoustic enhancement is just the opposite, okay. What we have learned that if there is a structure which is reflecting everything back to the transducer, we will not be able to see anything beneath that. Now, what happens in posterior acoustic enhancement? Supposedly we have a structure, okay, which is not like the blood vessels, okay. So they won't be reflecting anything back to the transducer. So what we will be able to see, there'll be an increased transmission to the structure, through the structure which is located beneath that. So that is known as posterior acoustic enhancement, okay. Then there is something called as reverberation. That is like you have a repetitive reflection back and forth between the two highly reflective surfaces. And this usually you will be getting it if you are going for an in-plane technique, okay. So always remember the image which you are looking on the top is the real one, and beneath what you are looking is your, it's an artifact. What you can do is just measure the depth and reduce the time gain compensation. So what you will be doing, you will be reducing the echoes which are going back to the transducer. So all these white lines will go off. Or the second thing which you can do is just change the angle a little bit. Okay, the best is to use this time gain compensation. This really helps. Okay, so that is reverbation artifact. And finally, how are you supposed to perform a very good block? Please do not just go and just put a needle. Always take a history, do the clinical examination, formulate your diagnosis, and then confirm your diagnosis with your US probe, right? Then do a preliminary scan, just find out whatever you are thinking, whether it is there or not. Explain the procedure to the patient, which we have already learned. So that was brain, okay? And then once you have, okay, and then, you know, your ergonomics needs to be very proper. You need to prepare your probe, and then you should be performing any of the interventions. I think that was all about the basics. So any questions you can ask me now, and after that I will be just demonstrating whatever we have learned.
Kanchan, you see there is some questions around topic name, ultrasound, UST. I didn't understand really what Dr. Arindam Mishra wanted to ask. So topic name is your basics of ultrasound.
UST, I don't think so. I have written anywhere UST.
So Dr. Arindam, are you there? Can you ask your exact question? What do you wish to ask? Dr. Arindam? You can unmute yourself and you can ask.
Okay, sir. There are
Ultrasound
some
therapy
other.
is something else. Ultrasound therapy, we are not talking about ultrasound therapy. What exactly is your question? You just unmute yourself and ask.
Okay,
Yes,
sir.
ma'am.
In the meet. Okay.
Anyway,
Yes,
you can
sir.
go for the demonstration.
Sir, there
Ma'am,
are
can
some
you-
questions which I would like to answer before I just explain them everything. There is one question from Dr. Mahmood. Okay, difference. See, Dr. Mahmood, if you are looking at hyaline cartilage, okay, remember that hyaline cartilage is more water. Okay, fibrocartilage, more fibrous tissue is there. Whenever you are looking at any fibrous tissue in ultrasound, so that is going to look hyperechoic, right? So hyaline cartilage will be homogeneously hypoechoic. But if you are looking at a fibrocartilage, that fibrocartilage is going to be hyperechoic, right? See, in ultrasound, when we will be demonstrating you, that time we will be discussing about the anatomy. So once we know the anatomy, we know that, you know, this is the articulating surface between two bones. So articulating surface, you are going to have hyaline cartilage, right? Articulating surface, you are not going to have the fibrocartilage, right? So that time, if you are looking at the two articular surfaces, and if you are able to see the homogeneously hypoechoic thing, so that is going to be your hyaline cartilage, right? But if you are looking, supposedly I'm looking at the shoulder joint, okay, shoulder, we have the labrum. Labrum is a fibrocartilage, right? So that fibrocartilage is going to look hyperechoic. So it is very important for us to understand that in ultrasound, what structure look like. If I'm looking at a muscle, how it should look, right? If I'm looking at a bone, how it should look. So that is what I was telling you, that do not think that, you know, that is hyaline cartilage, okay? That is fibrocartilage. Out of plane technique, any special advantage? Yes, there is one advantage, that, you know, you are reducing the distance, you know, from your skin to that structure. And usually out of plane technique, I would suggest you to go for very superficial structure, okay? And that's all. I think, you know, you just reduce the distance between the skin and your target structure, because in plane you have to come from a long way, so you will be like, you know, causing more trauma, and then you will be coming. It is like the shortest distance you are just reaching to the target. But please don't go for out of plane technique in your initial days, because that is very
No, but Kanchan, I used to add another thing for the out of plane technique. Means,
yes, sir.
you know, if your angulation, if you see that you cannot come from a distance, because already you have mentioned that to have the best visualization of the needle, your angle with the horizontal plane of the needle should be 30 degree, around 30 degree or even less. So sometimes you cannot come from a distance to make it an angle 30 degree or less. You have to have come at a lesser degree, higher degree, close to 90 degree. In that situation, you don't have the option to go for the in plane technique. You have only one option, that you have to go for the out of plane technique. Means you cannot come from a distance to make the angle less than 30 degree. So you have to come more perpendicular, and more perpendicular means you cannot visualize the needle. So in that scenarios also you can think of out of plane technique. But again, out of plane technique is always difficult, because you cannot see the structures which you are piercing. So it should be, the out of plane technique should be done by the, more seniors, more in more expert hand, because you are not really knowing which structures all you are piercing in the out of techniques. You cannot see the whole length of the needle. So out of plane technique should be reserved for those who are a little bit senior, who are more accustomed with handling the needle and the ultrasound probe.
Okay, posterior acoustic enhancement, once again, Dr. Jyoti wants to know. See, Dr. Jyoti, if you have a structure, so this is a structure, okay? Now, if my beam is going through it, okay, and this structure is not reflecting anything back to my transducer, okay, and there is one structure which is lying here. So what will happen? This acoustic impedance is very less, and this is very high. Okay, so less means everything is gonna go from that structure, and when it is hitting the tissue interface between a low acoustic impedance and high acoustic impedance structure, so the thing will be getting reflected. So the transmission of the deeper structure is gonna increase, right? So that is posterior acoustic enhancement. How do I prefer to cover the probe? I will be demonstrating, nothing to worry about. How to differentiate between tendon and ligament? Both are hyperechoic fibrillar, but tendon, if you trace it up, the tendon is going to become muscle. Ligament is from one bone to another bone. Okay. Time gain compensation. Time gain compensation is you can just increase the gain, and you can increase the number of echoes which will be returning back to the transducer from a particular depth. Okay. Uses of power Doppler in pain procedures. Yes, power Doppler is not dependent on your velocity and all. So we will be able to find out even the smallest vessel in any area. Usually we use it if we want to look for any neovascularization. Like if I want to look for a tendinosis in that particular area, I'll put the power Doppler and I'll see whether I'm able to see the neovascularization in that area or not. Dr. Arindam wants to discuss about pathways of pain. So that sir will be discussing. Nerve and tendon in long axis. Okay, nerve is going to be hypoechoic with hyperechoic. In the long axis, you will be having the fascicles and then the covering for a nerve. For a tendon, it is going to be hyperechoic fibrillar. There won't be any hypoechoic thing inside the tendon, but if you are able to see any hypoechoic thing inside the tendon, so that is pathological. Okay. Anatomy like skin, superficial fascia, muscle, tendon. I think I have explained it. Okay, so I will be just demonstrating you. That time you just have a look. Okay. Okay, so first let's have a look to the machine knobs. Sir, are you able to see my screen? Sir?
Muted. Yes, we can see.
Okay.
Yes.
So first we will understand the knobs, and then I will be demonstrating all the structures. Okay. So look at the cursor, which I will be moving. I hope you are able to see the cursor. Okay. So see this button. Okay. This is the one. Fine. This is the scroll button. So this is going to take my arrow wherever I want. Okay. This knob, scroll knob is this. Okay. Every machine, see, mine is Isaote. You can have Sonosite, you can have G. So D, so don't bother for all the knobs, different knobs which I'm having. Just try to understand the function of each knob, because that knob is going to be the same. That function of that knob is going to be the same in any of the machines. Okay. So the basic motto of learning the knobs is so that we are confident with what button we should use. Okay. Dr. Asim, my screen is visible to everyone. Dr. Asim, is it not visible to you?
Yes.
Then you should change your view. You put it in that speaker view, so you will be able to see it.
So you go in the right hand corner, there is a option of view. If you are clicking on the view, there is one option that is speaker view. So you click on the speaker view.
Okay, now you see. Okay. So this we have learned. There will be one button, enter button. Okay. So this is going to be there in every machine. All the machines will have this enter button. So this is that button. Okay, for my machine. And if you press it, whatever you want to type, or so you will be just entering. If you want to put the color Doppler, you want to move the box, so you should be pressing this enter button. You have this arrow cursor in all the machines. So if you will see, if I have switched it off, if I have pressed that button, the arrow is gone. So if I'm switching it, the arrow will come. Fine. Now there is something written as CFM. This button is for color Doppler. Okay. So if I'm putting this button, now you see this side some color has come, and this side one box has appeared. Okay. So when we are putting the color Doppler, so they will be assessing that particular area. So now we will be looking at the reflected echoes from that particular area. So a box-like thing will appear, right? Okay. There is one button called as power Doppler. Okay. So power Doppler, if I'm putting, this is what it will come. I will be showing you this also when I'll be demonstrating in that individual. Okay. And there is one button. All the machines will have B/M. Okay, so this is B mode, M mode, oblique. If you are lost anywhere in the machine, okay, you don't know where you have gone and you're not able to understand, just press this machine, press this button, you will be back to the screen, right? So these are the certain knobs which you should know. There is something, one big button, star will be there. So that is your freeze button. Fine. Now, just look at this, what we have learned. Before that, okay, let me discuss this. So this is my machine because the transducers are broad bandwidth. So I can use in the linear probe from a frequency 3 to a frequency 13. And this, which is reflecting here, is showing me which frequency I'm working with, right? So there is a knob. I can change this frequency. With the linear probe itself, I can go from 3 to 13. So look for the frequency button in your machine. Okay, some machines, they have fixed frequency. While some machines, you can change the frequency by just rotating the knob anti-clockwise or clockwise. Fine. Now, I was talking to you about the depth. So this side, this is the depth. See, there are certain marks which is written here, right? So that is going to show me the depth. I can increase, I'm decreasing. Now I can increase the depth. Okay. So see, now it is 5, 6. If I'm changing it, now it has become 1, 2, right? So that is the depth. And this, which I am moving, a small arrow, which you will be able to see, a triangular shaped yellow color thing, just on the, like where on the column where you are able to see the depth, right? So that is my focus button. Okay. So I have a knob here for the focus. Some machines, they have got autofocus facility. So you just try to look for that. Fine. And in this machine, every machine in fact, okay, you will be able to see the gain, how much you have adjusted. So you will be able to see this G over here. So that is going to be your gain, and D is your depth. Fine. So this is the whole picture which you should know. And since my linear probe is on, so what type of a screen I'm able to see? I'm able to see a square shaped thing, right? So that is the, because my linear probe is on, I'm able to see the screen like this. So I'll be just changing the probe and I'll be showing you how the screen changes when I'm switching on to my low frequency probe, right? And what I was telling you about the aspect marker is this, I have the logo. Some machine will have dot there, right? So that is the aspect marker, and this aspect marker is going to tell me how my probe is oriented, according to the body of the individual, according to that area which I am going to scan. Okay, now let us learn about the probe and let us quickly learn about the structures, because sir also needs to take this class, I think. Okay, so this is our linear probe. Why I'm saying it's a linear probe? Because this footprint is just like a line. Okay, so this is my linear probe, and just see, this is curvilinear probe. Why I'm saying it curvilinear? Because the footprint is curved. Okay, so that is curvilinear probe, and this is linear probe. Now, because my linear probe is on, you must be able to see that light over here, right? So this is going to tell me that in this machine, my linear probe is on, right? This probe also has got a light here, but since I have not switched on the curvilinear probe, so this is not showing any light, right? So now just have a look to the structures, how they look in ultrasound. Don't bother about the area and all now, because we will be learning all these things, all the areas in the subsequent classes. Today we should learn how exactly the structures look like in ultrasound. Okay, so first just have a look to the skin and the subcutaneous tissue. Okay, so before that, I will just tell you one thing. You have your quadriceps tendon. Okay, your quadriceps muscle is there. Okay, and your tendon will come and get attached here. So it means this quadriceps muscle is going to be like this. So if I am putting my probe like this, I am just looking at the structure in the longitudinal axis. Fine, this is what I was telling you. But if I'm rotating my probe like this, I am looking at the quadriceps muscle, but now at present I'm looking it in the short axis. Fine, this is what I discuss about the short and the long axis. Fine. So now see, okay, if I am looking, just concentrate. Okay, do not try to learn now, because we will be learning all this in our knee class. Just try to understand the axis, all those things, and try to get yourself oriented to the long and the short axis. Okay. So now see, if my probe is in the long axis, this is how it is looking. Okay. Because the long axis, this is how the quadriceps tendon is going to come, right? So now if I'm rotating the probe like this, so now see, the things have changed. It has become more oval, right? So this is what I just discussed about the long and the short axis. Now we will discuss about the aspect marker. Now if you see this light, okay? So this light, if I am touching here, okay? So this is the side where my light is, okay? And if this is the individual's thigh, this side, okay, is lateral and this side is medial, right? So if I am orienting my probe like this, so means this side which I am looking at is lateral and this side I am looking at is medial, fine? So I am looking at this picture like this, then my aspect marker is exactly according to the body of the individual, right? So the body of the individual means this side was lateral, this side was medial, my aspect marker was also towards the lateral side. Now, if I have not bothered about looking at the aspect marker, what will happen? Just see. Now I have changed, okay? Now my aspect marker is towards this side. Okay, my light is towards this side. Fine. And this side. Okay. So now my aspect marker is towards this side. So this side is medial. Okay. And now this is lateral. What you are able to see the movement, jerky movements on the ultrasound. Okay. So let me show you. Let me put the arrow. So earlier my aspect marker was like this. Okay. So light is towards me. So this was the lateral and this was the medial. So this is how the patient is lying down. This is how the volunteer is lying down. But if I have changed my aspect marker, I have just I've kept the aspect marker on the medial side of the patient. So now in my machine, this is the medial and this is the lateral. And if I'm doing an intervention, supposedly I want to do an intervention from the lateral to the medial, thinking that my medial will go from here. But in the screen, you will be seeing that your medial is coming from this side. So you will be like, huh, what has happened? I am putting it here, but I am able to see the needle coming from the opposite side. So that lies the importance of how are you going to keep your aspect marker. Okay, always check which side your aspect marker is. Now just let's have a quick look to our structures. So this is the tendon. Okay, so this is tendon. Tendon is hyperechoic with fibrillar pattern. Now see, my rays are not perpendicular. Okay, so that's why I'm able to see this hypoechoic area here. So this is how the tendon will look like. It is hyperechoic fibrillar, and if I trace my tendon up, this tendon is going to become muscle. And this is how the muscle will look like in the long axis. Okay, let me increase the gain further so that you will see nicely. Okay, so this is your epimysium. Okay, will come from the skin. Okay, so this is our skin. We have learned that skin is hyperechoic. Then we have learned that the subcutaneous tissue is hypoechoic with hyperechoic septations. So this is hypoechoic. These are the fat globules. And this is hyperechoic septation. So these are the connective tissue septations. Okay, so fat is from here to here. So this is our subcutaneous plane. And this one is our epimysium. Beneath the subcutaneous, we are going to have our quadriceps muscle. Okay, so this is going to be the epimysium, and what you are able to see inside the muscle is going to be your perimysium, and these are the muscle receptors, right? So this is how the muscle will look like, and tendon I have shown you. So let me show you the ligament also. So what we have learned that ligament is going to be from one bone to another bone. Okay. Oh, camera. Okay, fine. The volunteer is telling me, ma'am, camera is gone. Okay, let me freeze this image. So now what we are able to see here, this structure, hyperechoic thing from one bone to another bone is going to be your ligament, right? So ligament will always be from one bone to another bone. Tendon, if you trace it up, the tendon is going to become muscle, but the ligament will not become muscle. Okay. So that was about the tendon. Now have a look to the nerve and the blood vessels. And if you want to see the bursa, okay, before that, let me show you how the bone looks like. So I'm putting it over the patella. See, this is the bone. I am able to see only the hyperechoic thing. Okay, I'm not able to see anything beneath that. So this is how the bone is going to look like. And bursa, like we have prepatellar bursa. Okay, and that is there in the subcutaneous plane. So now he is a normal volunteer, and we do not have any bursal fluid, so we are not able to see the bursa, right? That's what I was telling you, that until and unless the patient is going to have some bursal pathology, you will not be able to see the fluid inside the bursa, right? So we have seen the skin, we have seen the subcutaneous tissue, muscle, tendon, ligament, and quickly I will show you the nerve and the blood vessels. Okay, Mali. Okay, so again, I'll be just showing you the median nerve. What picture we have here. Let me get the best picture so that we will be able to see that honeycomb pattern very nicely. That is the nerve. Okay, I'm just trying to get you the best picture honeycomb which you can see. Okay, so this is your median nerve. Okay, so this is how the nerve will look like, and from there, if we are changing it to the long axis, so that was the short axis we were looking at. Okay, and now if we will change it to the long axis, this is how the nerve will look like in the long axis. Fine, so that is the nerve we are looking at in the long axis. And the beauty of ultrasound is we can go for the dynamic examination of the ultrasound. Okay, like we want to see the flexor pollicis. So we can ask the patient to flex the thumb. So if he is flexing the thumb, you will be able to see the movement of your flexor pollicis longus, right? Which you will not be able to see when you are sending the patient for an MRI, right? And about the blood vessels, now let's have a look to the brachial artery. And let's have a look to the vein. Fine. See, I have not applied. Now we will look at this structure. Okay. So we are going to look at this structure. This structure has got a thin wall. Okay. It is not showing any pulsation. And when I am trying to compress it, this structure is getting compressed. So what it could be? It is ring, right? So if I am moving here, this side, I am again able to see one structure. And if you look at this structure carefully, this structure, you will be able to see the pulsation. And if I'm trying to compress it with my probe, I'm not able to compress it. So let me put the color Doppler there. So I put the color Doppler, okay? And now I'm seeing, but to be more specific, what I'm going to do is, I'm going to put the power Doppler. And I will see, look for the pulsation to be more sure, okay? And see, now I'm pressing the BM button and I'll come out. So I think briefly that was all about how the structures they are going to look in ultrasound, about the knobs. And do not worry, like, every time whenever we are scanning, we are going to teach you the scanning part. Every time we will be telling you how to hold the probe, where exactly will be the position of the patient, how are you supposed to keep the machine, where should be the aspect marker, what all are the structures you are looking at. Right. So this was just to get all of you acquainted to how exactly the structures are going to look under ultrasound. So any question you want to ask, you can ask me. If there are no questions, then I can ask sir to start his class. Sir, are you there?
Yes, I am here.
So
You have explained everything very nicely, but still there should be some questions. Any questions? You can directly ask.
And if you want me to demonstrate anything.
What about the artifacts? Can you demonstrate the artifacts in the patient as well?
Anisotropy I have demonstrated. Reverbation, because I need to get the needling done, and we are just demonstrating on the healthy volunteer. I cannot show you the reverbation. Posterior acoustic shadowing we have already seen. I think when I was putting it over the bone was appearing hyperechoic and there was nothing beneath the bone. So that was posterior acoustic shadowing, right? And what else is the artifact? I think that's all.
Okay. Posterior acoustic enhancement. Can you show
Posterior acoustic enhancement you want to see? Okay. Quickly, I will show you, not a problem.
Nerve, somebody want to see the nerve. Nerve will be seeing a lot of nerves in the different ultrasound scanning technique,
We have
So
two classes of
don't
nerves.
worry. So every time you'll be seeing a lot of nerves. Okay. One thing one thing, Kanchan, I have missed to tell at the beginning of the class. This is majority of the participants here are anesthesiologists. But remember, this is a pain management course, fellowship in pain management. So here we will be talking about the different nerve blocks which are relevant in the pain management. Some nerve blocks might be common in the both anesthesia and pain. So that might be, but we will not be covering the anesthesia nerve block. This is not a regional anesthesia fellowship. So here, please don't ask any questions related to anesthesia. Here we are going to demonstrate the nerve blocks or other different nerves important in the pain practice, which are done in the pain practice. Those regional blocks which are not done in the pain practice, we are not going to cover those topics. Okay, there are a lot more questions.
Okay, probe cover they want to see. Actually, I'm searching for a glove. It is upstairs. Okay, let me show them.
Difference between tendon and ligaments, Dr. Biswas, already Dr. Kanchan has demonstrated. When you are following a ligament, it will be ultimately, it is not going to follow a muscle, it will be attached with the bones. But when you are following a tendon, ultimately it will be forming a muscle. So you need to follow the either side. If you are following the probe on the either side, in case of ligament, you will be able to see that it is ultimately getting attached with the bone. But if you are following with the tendon, it will be converting into muscle. Already 2-3 times Dr. Kanchan has explained this.
Okay, now I'm showing you the posterior acoustic enhancement. Okay.
We cannot see your screen, Kanchan.
Oh, sorry. I have forgotten. I'm sorry. Okay. Is it visible now?
Yes, yes.
Okay. So I was just trying to look at the carotid. Okay. But since the machine was a little far, so not a good image, but still we can just see. So this is, something you are able to see an anechoic thing. And beneath that, you are able to see white thing. Okay. So that is your posterior acoustic enhancement, because there is no reflected echoes from the structure. And so there is an increased transmission to the structure, which is located at a deeper level. So when they're going to reflect the echo back, so you will be able to see it as hyperechoic thing. So that is posterior acoustic enhancement. Okay. How to select probe on machine? Actually, my machine, I have an option, so I will just show you. But many other machines, what options? Every machine has got a different option. So I think we need to look for that. See, I'll just show you with a closer look.
And some machine, like very basic machines, there you have to disconnect the probe and attach another probe. Suppose you used to using the linear probe, and now you used to use a curvilinear probe. So you have to detach the the linear probe, and you have to attach the curvilinear probe separately. But a higher end machines, there is some switch. If you are putting that switch on, you can change over from the either of the different types of the probes.
Okay, I'm just showing you now. See, there is an option called as probe in my machine, because it's a touchpad. I'm just pressing on this probe. Now, two options are getting displayed. One is for the linear. Linear is 3 to 13 hertz. Okay. And this is curvilinear, 1 to 8 hertz. So I'm just trying. Now I have pressed the curvilinear probe. Okay. And now, because I have a pre-select, so I'm just selecting the linear MSK. And now you see the screen will change. What we have learned is like the curvilinear probe is going to have the pot shaped screen. So you are able to see something like a pot now. And you see the depth, initial depth, which is 20 centimeter. But when we have switched on the linear probe, the depth was less. Dr. Jugal, I have already explained you, linear probe you should see for all the superficial structures. Okay. Curvilinear for the deeper structure, like hip. When you want to see something which is located at a deeper aspect, spine, you should use the curvilinear probe. In any obese individual, if you are not able to see with the linear probe, you should be going for a curvilinear probe. Differentiate between artery and vein in Doppler. I think I have shown you, Dr. Ishan. I have put the color Doppler on the brachial artery. And one more question which I would like to tell you is the probe covering. Quickly, I will show you how to cover your probe. How actually the cheap and best method, I'm just covering my probe. So let me show you. Okay. Okay. So this is the probe. So I'm just asking him to help me out. Okay. So what you can do is, you are like all, fully you have. So after having taken all the sterile preparation, what you are supposed to do? So I have washed everything, which I have not done right now, just to show you. What you need to do is you need to hold your probe like this. Okay, this is gloves. This is how I do it. You can use the glove cup, the sterile probe covering, but they are very costly. So that is going to increase the cost of your procedure. So if you can afford them, you can just buy them. But since I just want to keep the price of my procedures very low, so I'm using this technique, and this is equally good. Okay, so you can just stretch this gloves. This is the gloves which we are using. Okay, so you can just stretch this glove. Ask your helper to pour the jelly inside it. If you don't pour, just show them. So this is how, just show them. Okay, so we can ask him. You keep it here. So this is the jelly bottle. This is the jelly bottle. Okay, so we can ask him to pour the jelly inside, and then ask him to put the probe inside. And then we will be asking him to put the probe inside, and then we will be holding it from here. Okay, and then you can tighten it with a, like this, with a gauge piece. Now you can use betadine as your medium to look for the, in fact, you have the jelly also inside the gloves, and now you can dip it in betadine and you can just use this probe, and this is equally going to be sterile. So any more questions?
Indication for the linear and the curvilinear already told by Dr. Kanchan that if you wish to see the superficial structure, then it is linear. If you wish to see the deeper structures, it is curvilinear. And when we'll be scanning in the subsequent classes, subsequent modules, you'll be able to see when you are using the curvilinear and when you are using the linear probe. But as a rule, linear for superficial structures, curvilinear for the deeper structures. Okay, I hope we should start the next class, because I will be taking, at least 45 minutes. So already it is 7:50. So let us start the next class. And today we are going to extend a little bit. As I told earlier also, that please from next day, please log in proper time. We will be starting our classes at 6.
Okay, thank you everyone. See you in a moment.
Okay, thank you, Kanchan, for your very nice, lecture and as well as the demonstration on the machine. I hope participants, has cleared many of their doubts.
And don't worry, you are there with us for another 12 modules. So you will be learning more and more and more. Okay, we will make sure that you will learn and go. Okay, so thank you. See you in a while.
I hope all of you can see my slide.
Yes, sir, we can see it.
Yes, sir.
Okay, so remember that lot of concept you need to develop if you wish to do a pain management, pain practice. One of the very important area is your pain pathway. Pain pathway, many might be thinking that, okay, what's new? We have started it in our undergraduate studies. The first year itself, we have learned about the pain pathway, but there are a lot of gaps. So before going into this lecture, I normally, I'm giving this lecture since 2008 when we started our the classes. So a simple question to all of you. You know the answer, but still I'll be asking this question. That I'll be taking a drop of blood for the capillary blood sugar. So I'll be pricking a small needle and you'll be feeling pain. So because I am the person who is taking the blood, the needle is same gauge, same depth, same technique, I am taking the blood. So the tissue damage in the fingertip should be same, isn't it? So will the pain be same in our person? Because the tissue damage to take this drop of blood is same. So theoretically, the pain should be the same, but you all know the answer. The pain is not same. Pain is different in different persons. If you are 100 persons in this group audience, and if you are taking their blood, all 100% will be having the different amount of pain. So answer is why? Because in our undergraduate studies, even in the postgraduate studies in the anesthesia and other branches, whatever you have learned, that the pain is because of tissue damage. So if the tissue damage is same, theoretically at least, the pain should be same, but you know answer that the pain is never same. Never. And this is the biggest mistake we all physicians do. Suppose somebody is tossing in pain, very severe. What is my automatic reaction as a human being? I have seen this several times in the OPD. Somebody is, patient is coming with a lot of pain, tossing, crying. And immediately our staffs, our fellows, everybody becomes alert and starts thinking, okay, probably this person is having very serious. If you're touching, patient is jumping, shouting, and we are thinking, okay, probably this person is having the, lot of, very bad disease behind it. But answer is no. Answer is intensity of the pain, just now we told that pain varies when the tissue damage is remaining same. The same way, if somebody is having a lot of pain, somebody having the minimum pain, that cannot tell you the intensity of the tissue damage. It means the intensity of the pain and the amount of the tissue damage, they do not correlate. This relationship between the tissue damage and pain do not match. And we have to understand it very nicely. Even there are a lot of conditions where there is no tissue damage, but still there is pain. So in this pain pathway lecture, a very, very important lecture, I tell, all the lecture, whatever you'll be listening in this 13 modules, I'll be telling you this pain pathway lecture is the most important to understand what is pain. To become a pain physician, you must be understanding the pain pathway very nicely. So I'll be trying to answer this question. Why the same tissue damage is going to produce different pain in different persons? So I'll be at the end, I'll be taking this question again. So let us start. So we know that the pain pathway can be broadly divided into 4 headings: transduction, transmission, perception, and modulation. I have given this modulation in a different bold color and a different yellow color. Why? Because in our undergraduate and postgraduate studies, we know about the first 3 steps: transduction, transmission, and perception. But modulation, most of the textbook, even in our anesthesia books, we have not read about what is called pain modulation. We have read the pain pathway in our anesthesia book as well, but I don't know whether the recent book is covering. But the modulation term is not there. But without understanding pain modulation, your understanding of the pain pathway is completely incomplete. So let us see. I'll be going to this. I'm just skipping these slides. I'll be going directly into this schematic diagram. This is described as schematic diagram, so don't correlate with the anatomically drawn by me. So a lot of mistakes are there. This is just to understand the basic headings. So first is transduction. What is transduction? Transduction means generation of action potentials. What is an action potentials? So action potential is an electrical signal. So how this electrical signal is generated, in particularly when we're talking about the pain? So we call frequently that a noxious stimuli. So what are the noxious stimuli which can generate action potentials or electrical signals? So there are nociceptors. Nociceptor means these are the receptors which is basically transforming these different forms of energy into electrical energy. So this transduction process means it is the conversion of the different kinds of energy into an electrical signal. So what are these different kinds of energy? This can be mechanical. You are pressing too hard mechanically and you might be feeling pain. So mechanical energy, or you are having a scratch in the skin, you might be feeling an energy pain. So this mechanical energy is converting into an action potentials. What else? It can be some chemical energy. When there is some injury, some chemicals are produced, or if you're injecting some chemicals or alcohols. So there is some chemical energy which is converted into a electrical energy. Or if it is a thermal energy, if you are giving the heat and you are having pain, so there is a thermal energy. So thermal energy can also be converted. So these nociceptors, what they're doing, they are converting one kind of energy into an electrical energy, and this process of conversion of the energy into electrical energy or electrical action potentials, this is known as transduction. So this is one of the very basic things to understand the nociceptive pain. So later on we'll be discussing about the nociceptive pain and the neuropathic pain. So in the nociceptive pain, this role of nociceptor is very important. So nociceptor is converting one kind of energy, particularly these 3 kinds of energy, like the mechanical, thermal, and chemical energy, to convert into an electrical energy or action potentials. So this is your first step, transduction. Next step is transmission. So through the 3 different, first order neuron, second order neuron, third order neuron. First order neuron is by the up to the dorsal horn, then second order neuron up to the thalamus, from thalamus to third order neuron to the postcentral gyrus. This is how and there are two types of nerve, adult and C fibers, which is carrying pain. So this is your transmission. I'm not going to the details of this, different tracks, different nerves, different nuclei in this pathway. Just to in simple way to remember that the two different types of nerves and three orders of neuron: first order, second order, and third order. Next important area, again, which we need to know a little bit more detail, is your perception. So what we have what we have studied in our undergraduate studies and the postgraduate studies is from thalamus, these fibers are reaching the post-central gyrus, and that is your sensory area. So that area, the signal is reaching, and we are feeling pain. So this is, we all know, but this is your incomplete understanding of perception. If you're looking about the definition of the pain, can you remember what is the definition? I will come to this definition later on again. So pain is an unpleasant sensory and emotional experience, isn't it? This is a standard definition of the ISP. In fact, in every textbook, not only for the anesthesia book, if you're talking about the orthopedics books, if you're talking about the physical medicine books, the definition is same. Pain is an unpleasant sensory and emotional experience. That means it's not just the sensory feelings. Post-central gyrus is responsible for our sensory component of pain, or we can call it physical component of the pain. But what about the next component? Pain is an unpleasant sensory and emotional component. So where is the emotional component? Which higher centers are responsible for this emotional component? So I'll be sharing this slide. So this was functional MRI studies, and this was done during somebody, when some person is having very severe pain. And what was seen that the different areas of the brain starts firing, and they can be grouped into these four major groups. One group is your post-central gyrus. This is responsible for your physical pain. But this is also very, very important. Limbic nuclei. Limbic nuclei, not one nucleus. Nuclei scattered in the different parts of the brain. And that is responsible for the emotional changes. So pain is an unpleasant sensory and emotional experience. So first part, post-central gyrus is getting, it starts firing. That is explaining your physical component, and the limbic nuclei also starts firing in the different parts of the brain, which is explaining your emotional. So we cannot, describe a pain which don't have an emotional component. Then what do you have to do? The projection fibers from thalamus, when they're reaching in the different parts of the limbic nuclei, you have to all ablate surgically. Then only we can be getting some pain, which is only physical pain, without having an emotional component in it. It is absurd. It is not possible. So all pain have emotional component, and this is how physiologically you can explain it. That the fibers, the third order neuron from thalamus is not just reaching the postcentral gyrus, they are also scattering in the different parts of sending signals to the different parts of the limbic nuclei as well. But this is not the end of the story. There are two other important areas which are also receiving signals. What are those? One of them is reticular network, reticular formation. And you just remember the student life, hostel life. Your roommate is sleeping, you are calling and still not. What you are doing? You're pinching little bit and patient will be awake. Also seen in the post-operative ward, patient cannot sleep unless you are taking care of the pain. So what is the mechanism? Mechanism is this fibers, projection fibers are also sending signal to the reticular network, reticular formations, keeping the us awake. So this is the third important area in the higher centers. And the fourth important area is your periaqueductic gray matter. In the fMRI studies, we also see these areas. PAG, the PAG, they are also getting stimulated. So coming back here, So remember that these are the four important areas in the higher center. So perception is not just the post-central gyrus stimulation. Perception means it is the four important areas of the brain which are getting stimulated. So now we'll be starting with the periacortical gray matter stimulations with an animal experiment. So what was done in this experiment, that in the experimental animal, so what was done, the electrodes were placed in the periaqueductal gray matter, and with an external source of the electricity, the periaqueductal gray matter was stimulated, and then bilateral on either side, and then laparotomy operation was done on the animal, and the animals in the animal model, they didn't feel any pain. So then the scientist starts thinking, what is the mechanism, how it is possible? And then ultimately the descending pathway was discovered. In the pain, is the ascending pathway, descending pathway is also very, very important. So this descending inhibitory pathways are two. One is inhibitory, another is also the stimulatory. But that is a very small pathway. Mostly whenever we are talking about the descending pathway, remember the descending inhibitory pathway is the strongest pain modulation system. So this system starts from the periacortical gray matter, and then via the different other nuclei. In the schematic diagram, I have omitted that to make it more simple. So this descending inhibitory pathway starts from the periacortical gray matter and then ultimately sends signal where? In the dorsal horn. So in the dorsal horn, where the first order neuron was sending signal to the second order neuron, at that area, the descending inhibitory pathway sends the signal. And what it does, the first order neuron sending second order neuron, the action potentials, they are getting suppressed. And the descending inhibitory pathway can be so strong, like we told in the animal experiment, then it can completely suppress the signals coming from first order neuron to the second order. Now, let us see a little bit more details about it. What happens? So the signals, when it's reaching to the other side thalamus, the signals coming to the same sided periacortical gray matter. Means if the injury is on this side, then the same sided periacortical gray matter will be stimulated. And then here, two important neurotransmitters will be released. As a pain physicians, this part is very, very important. Listen very carefully. So the periacortical gray matter, there will be release of two important neurotransmitters, the serotonin and norepinephrine. And these two important neurotransmitters, they will be activating, stimulating the descending inhibitory pathway so that the action potential travels down and it comes here into the dorsal horn, where the first order neuron was sending signal to the second order. So here some again chemicals will be released. What are those chemicals? These are endogenous opioids, and which will be taking care of the pain signals starting from first order neuron to the second order. So now this is a body's own homeostatic mechanism. That means suppose somebody is having pain, the body will try to reduce its pain. And one of the very important mechanism is using its own pain modulation system. So what is pain modulation? Pain modulation is endogenous mechanism in a healthy individual to suppress the feelings of the pain is called the pain modulation. So few things to remember. One is, this is the natural, endogenous, physiological. It is seen in the all healthy individuals. If somebody is feeling pain, our mother nature will try to reduce our sufferings. And one of the very important mechanism is your different pain modulation system. Pain modulation is the mechanism. So here in this pain modulation system, there are four important headings we'll be discussing. One of them is descending inhibitory pathway. Three others I'll be discussing later on. So first, you try to understand this descending inhibitory pathway. So this descending inhibitory pathway is starting from periacortical gray matter of the same side of the injury. It starts with the release of the serotonin and norepinephrine. When these are released, they are stimulated. They start sending the signal downwards. Via the different other nuclei, ultimately they're sending signal to the dorsal horn and they are releasing the pain. So now suppose I am having a chronic condition. Suppose, say, for example, very simple example, I am having osteoarthritis knee. So what will happen? I'm having pain, not for one day, day after day, week after week, month after month. So my body will start its action to reduce my suffering. How to do that? By activating the strongest pain modulation system, that is your descending inhibitory pathway. So descending inhibitory pathway will be how it will be activated. So body have to release serotonin and norepinephrine. So if the serotonin and norepinephrine is released in the periaqueductal gray matter, so my descending inhibitory pathways will be activated and my pain will be reduced. So my pain will be reduced 1 day, 2 days, 1 week, 2 weeks, days after day, months after months. What will happen? So gradually this system will be exhausted. It will be exhausted means initially when my pathology, suppose my pathology remains same, but still over the period of time, I'll start feeling more and more pain. So this is in contrast to the popular belief. If you're asking somebody that, okay, please tolerate the pain, gradually you'll be getting the tolerability. No, opposite thing happens. If you're allowing somebody to feel pain for the longer time, the descending inhibitory pathway gets exhausted. The stores of the norepinephrine and serotonin will be depleted, and it will, natural pain inhibition process will be gradually exhausted, and I'm feeling more pain even if the pathology is remaining same. And now I visited a pain physician, and my pain physician has prescribed a drug which is elevating serotonin and norepinephrine. What is the drug? An antidepressant. So antidepressant drug elevates serotonin and norepinephrine. So he has prescribed me an antidepressant, say for example, amitriptyline 10 mg, and after using 1 to 2 weeks, my pain gradually starts reducing. So this is the mechanism how antidepressant work in chronic pain. So again, I'm telling you, I have, in different lectures, I have seen this is a very common myth, very common misconception, how a antidepressant work in a chronic pain. So this is the mechanism. Remember that here you need to select a drug which elevates both serotonin and norepinephrine. Only serotonin, that is for depression. So we are having the different classes of antidepressants. One of them is SSRI, selective serotonin reuptake inhibitor. Is it a good drug to treat pain? Answer is no. Why? Because it is elevating only serotonin level. No action on the norepinephrine. In fact, norepinephrine is more important here. So SSRI group of drugs like escitalopram, the sertraline. So this kind of drug are very important to treat the depression, not for the pain. And another very important things to remember, that this antidepressant dose and the pain management dose are not same. Suppose you are treating the pain. I told you I have visited a pain physician. I'm having osteoarthritis knee. My pain physician has prescribed me amitriptyline 10 mg. 10 mg might be enough. But suppose if you wish to treat a depression patient with amitriptyline, what will be your dose? 10 mg? 25 mg? You have to prescribe at least 75 mg to treat the depression. So this calculation, and this is one of the very important, people start thinking, okay, this patient's pain is responding on antidepressant. That means it is not a real pain, So he might be having the depression, and that is why the antidepressant works. So this calculation, never do it. Many times chronic pain and depression is coexisting. That is a different issue. But how antidepressant works in a pain is not by correction of depression. You remember this, that antidepressant works by stimulating the descending inhibitory pathway, by elevating the level of the serotonin and norepinephrine at periaqueductal gray matter, and that is how here is the role of antidepressant in chronic pain, right? But of course, There are certain conditions where the chronic pain and the depression is coexisting. So you need to take care of the depressions as well. So in that situation, you have to increase the, the dose. So that is a different issue. But if the patient don't have, so in the evaluation of the patient, you have to also evaluate whether the patient is having the depression as well. If the patient is having depression, so that is a different story. I'm not talking about that. I'm talking about the chronic pain without depression, and there antidepressants also have a very important role. And how it works? This is how it works. Next important area of the modulation. So we are discussing about what? We're discussing about the pain modulation. Pain modulation, I told you, 4 heading. One of them is the descending inhibitory pathway, which starts from periaqueductal glutamate to the dorsal. Next important area, again very important for the anesthesiologist also, but for the pain physicians also. This is called as one of the very important milestone in the history of pain. This is your discovery of gate control theory. And do you remember the scientist's name who discovered? Meljack and Wall. 2 scientists, Meljack and Wall. So the Meljack and Wall, they actually in 1965, their paper were published, gate control theory. What exactly is the gate control theory? So this gate, what is the gate? Gate is here at the dorsal horn. So that dorsal horn, the large diameter fibers, small diameter fibers, all are entering. Say for example, large diameter fiber is your touch fibers, A beta fibers. Small diameter fiber is your C fiber, A delta fibers. So at the dorsal horn, if large diameter fiber is sending signal, so they send some inhibitory signals via some interneurons and close the gate for the small diameter fibers. I just asked the patient to remember in a very simple way that the gate is controlled by a thick muscular man, and he don't allow the thin person, weak person to enter to the gate. So large diameter fibers, when it is stimulated with the help of the interneurons, it stops the gate, closes the gate for the smaller diameter signals to enter into the gate, to cross the gate, to go to the second order neuron. And there are a lot of practical applications of it. So one of the very important, we all know that suppose a baby is having a pain abdomen. So mother, what is doing? Moving his hand over the abdomen. How it ends? When you are moving the abdomen, hand, it is creating the touch signal. A beta fibers are stimulated, and it closes the gate for the pain fibers. But remember one very important thing what to know, it must be same dermatome. That means you must be closing the same gate. Suppose somebody is having a pain abdomen and you are moving your hand on the head. Will the pain be relieved? Answer is no, because it is closing the other gate, not for the signals which is entering through this gate. So the stimulation must be on the same dermatome. Then only gates will be closed. And 2 other important, one of them is applications. One of them is very historical again. Just now I told when the gate control theory was first discovered or first published by Meljack and Wall in 1965. And very soon, after 2 years, the first spinal cord stimulation was implanted by a neurosurgeon, Seeley. You must have heard about the spinal cord stimulator. You know what is spinal cord stimulator? Spinal cord stimulator is like a cardiac pacemaker. It is also called the spinal pacemaker. So there will be a battery, just think of a the cardiac pacemaker. So there is a pulse generator, or electrical signal generator, battery, power generator. It's also called the implantable power generator, IPG, and that sends the electrical signal through the electrodes, 2 electrodes to complete the circuit. So earlier, when the Seeley was first implanting, it was basically 2 electrodes, bipolar. So ultimately, this electrodes was implanted into the epidural space by laminectomy. By laminectomy, they removed the bone and then implanted it. But nowadays, laminectomy is very rarely done. Mostly, it is done by us, pain physicians, putting the needle and epidural needle, special kind of epidural needle is needed, through which we are putting the electrodes into the epidural space. So, what is the mechanism of action here? That this IPG will be creating the electrical signal, which will be stimulating specifically the larger diameter touch fibers. How to do that? Again, we'll be discussing when we'll be talking about the, in detail about the radio frequency, but just briefly, because this is one of the very basic knowledge you also be having it. So we know that there are, the alternating current, direct current, direct current means current will be flowing from one electrode to the another. And alternating current means it will be changing its direction from the one to another. So alternating current, so when we are using NARF stimulator, what kind of current we are using? Direct or alternating? I know whenever I ask this question in the classes, I have seen the many answers, it is a direct current because we are using a cell. Cell delivers direct current, but your NARF stimulator machine is converting that direct current into an alternating current. Alternating current is needed for stimulating the nerves, and the frequency of the alternating current means how many times it is changing its direction. I just told you alternating current means it is changing its direction. So how many times it is changing its direction? So that causes the, what is the frequency of the alternating current? It is denoted by Hertz. So the Hertz is the frequency. So this is a rule you should be remembering. Have you noticed it? When you are doing a motor stimulation, nerve stimulation, what is the Hertz how many Hertz current you are delivering? Normally 2 Hertz or even 1 Hertz. So for the motor fiber stimulations, we need a lesser Hertz. The range is, most commonly we give 1 to 2 Hertz, but the range is 1 to 10 Hertz. That means between these frequency or alternating current, you can stimulate the motor fibers, right? So if we are increasing the frequency, radio frequency machines and some other, majority of the nerve stimulator, you cannot change the frequency too much. But in the radio frequency machines, we can change this frequency. So this, if you are increasing the frequency, so if you are giving the frequency at a range of 20 to 40 Hertz, then you will be able to stimulate the touch fibers. If you're still increasing it, 50 or more, then you'll be stimulating the pain fibers, A delta C fibers. That means the more you are, increasing the stimulations, the frequency of the stimulation, you'll be able to stimulate the smaller diameter fibers, leaving behind the larger diameter fibers. That means it is inversely proportional. The thicker is the nerve, you need a lesser frequency of the alternating current, and thinner is the nerve, you need a higher frequency to stimulate. So coming back to the spinal cord stimulators, what was done there? So it was delivered a current of 20 to 40 Hertz to stimulate the touch fibers, and if the touch fibers is stimulated, what will happen? The gate will be closed for the smaller diameter fibers, so the patient will not be feeling pain. So this is your gate control theory. This is also a very important, the pain modulation. 2 other pain modulations I'll be talking. One of them is called the segmental inhibition. Segmental inhibition. So what is segmental inhibition? Segmental inhibition, again, go back to the first year physiology class. Remember that there are certain neurotransmitters which are called excitatory. That means first order neuron to second order neuron. If excitatory neurotransmitters are released, then the next order neuron, the action potentials will be accentuated, will be increased, amplified. Whereas if the neurotransmitter is the inhibitory, then it will be dampened, it will be reduced. So if the neurotransmitter released neurotransmitter is your inhibitory, then what will happen? Your pain will be relieved. So what are the examples? GABA and glycine are 2 very important inhibitory neurotransmitters. And when these inhibitory neurotransmitters are released and the reduction of the pain, this mechanism is called segmental inhibition of pain. And the last one in modulation is your endogenous chemicals, endogenous opioids and cannabinoids also. Nowadays, cannabis is getting very important. You are understanding gradually that not just opioids, the endogenous cannabinoids also have very important. So they can also release, and one of the mechanisms I told you that the descending inhibitory pathway ultimately work is action is because of the release of this endogenous opioids. So endogenous opioids and the cannabinoids can also release the pain. So just let us summarize. One is your pain transduction, Transduction means the noxious stimuli, if it is reaching the crossing the threshold, then it will be converting one kind of energy to another kind of energy. That means electrical energy. Who is converting this? Nociceptors are converting it. And this process is called transduction. Next is your transmission. First order neuron, second order neuron, third order neuron, and two types of nerves. Next important area is your perception. And the perceptions in the higher center, we have to remember that there are four important areas. One, not just the post-central gyrus. You have to remember the limbic nuclei. You have to remember the reticular formation. You have to remember the periaqueduct nuclei. And then the modulation. Out of all these, modulation you have to remember very nicely. Modulation, one is your descending inhibitory pathway. Second one is your get control theory by Melchek and Wall in 1965. Third one is your segmental inhibition. And fourth one is your endogenous opioids and cannabinoids. So my lecture is not over. There is a very important part I'll be talking. So one part, to go by my question. One question was that one part was why the same tissue damage is going to produce different amount of the pain in different person. One answer, this is partial answer, you already got it. That modulation system is not same in all persons. Some person who is having pain for a long time, their modulation system might have been exhausted. So they may be sensitive to pain. Most very small stimuli. You must have seen, you are giving local anesthetic for the regional anesthesia. If you're just pricking, some people jump. We have seen in our regular patients also. Those patients who are having a very chronic pain, if you're giving a small local anesthetic, small prick, they jumps. Why? Because their modulation system has been exhausted. So I'll be inviting some quick questions before going to the next slides. So if you have any, this part is very, very important, as I told you, to understand the pain modulation system as well as the higher centers. You can quickly ask me questions. Then I'll be going to the another very important aspect, which is called pain amplification. Just now we have discussed about how physiologically the pain is reduced. Now, next other important part is that electrical signals produced at the periphery can be amplified when it is reaching the higher centers. So this amplification process also you need to know. Right now I have talked about the dampening system, the reduction system, that is called modulation. And next part is called sensitization. So you have to understand the sensitization also. Before going into the sensitizations, I'll be inviting one or two quick questions regarding your the modulation. You can unmute yourself and you can quickly ask the questions.
Good evening, sir.
Yeah.
Hello. Can I know certain points about endorphins, the endogenous opioids and other thing which you told? It was, I could not hear it properly. There are two endogenous
details of the endorphin and endogenous opioids. I'm not going to cover it. Just remember that in the pain modulation systems, there are certain chemicals, endogenous opioids. Endorphin is one kind of endogenous opioids, which when it is released, it can dampen the pain signals. So this far is enough for time being.
Right.
Good afternoon, sir. I mean, Dr. Manish. Actually, I had a question. I just wanted to clear what is the role of segmental inhibition in the pain modulation part. I couldn't get it clear. If you can explain once more.
There are inhibitory neurotransmitters. So these inhibitory neurotransmitters, when it is released, the pain signals will be reduced. Pain signal will be dampened. Again, this much you should know. Further details, beyond the scope of this. Just one thing I can tell you. Please unmute. Please mute yourself. Please mute. Please mute. Okay, so what is going to tell that segmental inhibition is release of the inhibitory neurotransmitters. mostly the GABA and glycine. I mean, if you're asking me how to, take the help of this mechanism, take the help of this mechanism, sometimes it has been seen that particularly when you are using the TANES or spinal cord stimulator, I told the gate control theory is the most important mechanism when the spinal cord stimulator, you are giving the electrical signals in the form of the spinal cord stimulator or the transcriptase electrical nerve stimulation another. But again, when you are giving this kind of stimulations, electrical signals, it is also seen that this endogenous, these inhibitory neurotransmitters are also released for the segmental inhibitions. So we are just talking about the mechanisms. Practical applications, separately how to use this system for the pain management is basically, we should know that these are the 4 headings, but many times when you are giving the stimulations, the multiple things act together. That means when you are using the one mechanisms, along with that, the other things are also working. Like along with the gate control theory, the segmental inhibitions also will be working. Along with the descending inhibitory pathways, endogenous opioids mechanisms is also active. Okay, clear?
Yes, sir. Thank you, sir.
Sir, there are 2 questions in the chat, sir. Dr.
Yes.
Mahmood wants to know, could you please repeat the part about SSRI and why not in pain? And there is one more question from Dr. Bikas. He wants to know about the dose of antidepressants. Are they same in depression and chronic pain? And which antidepressant we are supposed it's going to be the best in chronic pain?
So the first question is, what was the first question?
So what is, okay, let me just see it once again. First question is by Dr. Mahmood. He wants to know, can you repeat this part about SSRI? Why not in pain?
Okay, just there are there are a lot of different classifications of the antidepressants. For the pain physicians, you remember these classifications very simply. One is your tricyclics. So tricyclics antidepressant, their mechanism is elevating the, I'm not going into the detail, please don't ask the details, because then I'll not be able to cover the other parts of this lecture. So the tricyclic antidepressants, they are, the very commonly used, one of them is the amitriptyline, nortriptyline, a few others are there. They share, there are different classes of the chemicals, and they share the, the anticholinergic side effects. So tricyclic antidepressants, once it was used very frequently, nowadays it is used less because of the anticholinergic side effects. So a lot of different anticholinergic side effects are there, but they are very helpful. So the doses of the amitriptyline, when you are using the pain management, is around 10 milligram to 25 milligram maximum, 5 to 25 milligram. But when you are using in the depression, the dose starts from the 75 to 150 milligram is the antidepressant dose. So now this is your tricyclic, one class of antidepressants. Second class of antidepressant is your SSRI, selective serotonin reuptake inhibitor. By the name you can understand, it elevates only serotonin. It do not have any action on the norepinephrine or noradrenaline. So what will happen? Only serotonin will partial reduction of pain, not much. So serotonin is most important for mood elevation. So the SSRI drugs are used for mood elevation, means in depression. They are very important drug, but not for management of the pain. And third class is your SNRI, serotonin, norepinephrine, reuptake inhibitor. These are like that of the tricyclics, but chemically they are different class of drug. So they don't have the anticholinergic side effects much like that of the, some anticholinergic like side effects might be there, but very moderate. They have the different side effects like nausea, some other, the dizziness might be there, but otherwise this SNRI group of drugs are better tolerable. And there are in fact these drugs are most commonly used and US FDA approved for the different painful conditions. Most commonly used your duloxetine. Duloxetine is an antidepressant dose, around 80 milligram to 120 milligram. But for the pain management, we use 20 milligram to 60 milligram is your pain management dose. As I told you, pain management mechanism and the antidepressant mechanism is different. Antidepressant means you have to elevate the serotonin level, and that elevation level needs much at a higher level to elevate the mood. But for the pain management, little bit of elevation of the serotonin and norepinephrine is enough to stimulate the descending inhibitory pathway. And that is the reason why at a very small dose, you will be getting the pain relief. But at the very small dose, you will not be having the antidepressant action. For the antidepressant action, you have to elevate the level much, dose much more. So this was one question. What was the next question, Kanchan?
Next question is dose of antidepressant are the
I have already told that.
And there is one more, I think, sir, or the pharmacology question we can take up because we have a class on
Yes,
pharmacology.
we have a pharmacology class. We'll be discussing this all these things again.
Dr. Sunik wants to know, how does preemptive analgesia work?
Again, at the beginning I told you that okay, this anesthesia question, please don't ask. We'll be just covering the pain management part. Preemptive analgesia is purely anesthesia subject. You read your books and you see the what of the mechanisms of the preemptive analgesia. Any other questions?
No, sir, I think that's all. There was one question of pharmacology. I think we can take
Okay,
up
we'll be covering those pharmacology questions also.
Yes,
Because
we have a full class
questions.
on pharmacology. Don't worry.
And again, I'll be requesting all of you, because I understand many of you are the anesthesiologists. Naturally, your anesthesia question is bound to come. But again, I am telling you, we'll be covering only those parts which are related to the pain management, not related to the anesthesia. Okay, so now I'll be going to the next other important part. Now this part I'll be just cover. I'll be starting from here. So what is phantom limb pain? Phantom limb pain means somebody's limb has been amputated. Say for example, the hand is amputated or leg is amputated, and the person is feeling that my fingers are there, my hand is there, and the pain is coming from that part. So this feeling of a phantom limb and phantom pain coming from that phantom limb is basically phantom limb pain. So phantom feelings of phantom limb and phantom pain, normally they are coexisting together. But it is also possible that somebody might be having the feelings of phantom limb, but may not be having pain all the time. Sometimes they are just having the feeling that I'm having still having my fingers, my wrist, but may not be having pain. But majority times they also have the pain. So now the question is, what is the mechanism? Earlier, until the 60s, 70s, people used to think that probably one limb has been amputated, has lost one limb, and a lot of psychological trauma, and this is an aberrant psychological reactions. That is the reason why it's happening. But later on, it has been proved that limb has been amputated. Say for example, for my elbow. So my fingers are not there, my wrist is not there, but the nerve which was taking signals from my fingers, are they alive? Answer is yes. Why? Because their cell body, their axons might be amputated, dendrites might be amputated, but the cell body is here at the dorsal root ganglion. So they are still there. So first order neuron, which is taking signals from my fingers, my wrist, there. The second order neuron, still there. Third order neuron, there. Higher centers, there. So now, if there is any signals, similar kind of signals are generated in this remaining part of the nerve, which was processing my fingers, my wrist, I might be feeling the pain is coming from my fingers, because the nerve which is processing signals from my hand, from my finger is still there. And this is the mechanism of phantom limb. Phantom limb pain is a very complex one, but still you need to know that the nerves, there is a signal generation in the remaining part of the nerves or in the higher centers. So that is how the phantom limb pain is there. So here, why I have given this example of phantom limb pain? Just to compare that we have discussed about the nociceptors. So there is a nociceptors, I am having a finger pain. So nociceptors in my fingers are generating action potentials and I am having pain. So this pain is called nociceptive pain. So here, the nociceptors are getting stimulated by thermal, chemical, or mechanical energy. How? By other than the nerves. The nociceptors are getting stimulated. Nociceptors are normal. Nociceptors are physiological. The nerves are there, normal, intact nerve. If my nerve is also damaged here, so these signals will not be reaching my brain. But if the nerve is intact, if there is a damage, if there is mechanical, thermal, chemical injuries, then that is going to create the action potentials. So here, the intactness of the nerve is important to send this signal to the brain. So this is your nociceptive pain. The second kind of pain, what I discussed, here the nerve itself is damaged. And the kind of pain produced in the second kind of pain, because of the nerve damage, there is some pathological signals within the nerve without having the external sources, which is converting the energy through the nociceptors. So this kind of pain is called neuropathic pain. So phantom limb pain is a classical example. So this is the two broad types of pain. I'll be discussing about the third type of pain as well, but now concentrate on these two types of pain: nociceptive pain and neuropathic pain. So neuropathic pain is because of the non-neural tissue damage and conversion of energy. This is your nociceptive pain. And neuropathic pain, it is the damage, it is the pathology of the neural structures itself. That is why nociceptive pain is also called physiological pain. Why physiological pain? Pathology is there, but that pathology is not involving the nerve. The nociceptive system is intact. It is doing its own physiological action. So that is the nociceptive pain. Whereas neuropathic pain, here the nociceptive system is pathological. There is damage in the nociceptive system, and that is how it is called pathological pain. Nociceptive pain is easy to diagnose. Simple relationship: this much tissue damage, this nerve is damaged, so this much pain. But this relationship is dissociated between the pain and the tissue damage in the neuropathic pain. Neuropathic pain is very difficult to diagnose, very difficult to treat, because it is not only one area, a lot of different other areas of the whole nervous system is getting involved. So difficult to diagnose. There is no simple test. There is like hypertension, like diabetes. So most of the time we are having certain bedside tools, some questionnaires based on which you can make a diagnosis of neuropathic pain. So difficult to treat is your neuropathic pain. Now, nociceptive pain can be sub-classified into inflammatory pain, like say, for example, rheumatoid arthritis, spondyloarthritis, ankylosing spondylitis. These are the inflammatory changes. So inflammatory pain, visceral pain. Suppose somebody is having an appendicitis, somebody is having the gallbladder stone. So these are visceral pain. So these are also nociceptive pain. So these are the different varieties of the nociceptive pain. Whereas neuropathic pain, there are certain varieties like neuralgia. So what is the difference between the neuralgic pain and neuropathic pain? Are the same? And this is a very basic question, and I have seen when I ask these questions to the participants, many of them have the confusions. So please clear this confusion. What is a neuralgic pain and what is a neuropathic pain? So neuropathic pain is a broad basket. It's a broad term. Whenever there is a damage or dysfunction of the nerve and that is creating pain, that is your neuropathic pain. And what is neuralgic pain? Neuralgic pain means if a pain is limited within the anatomical boundary of a particular nerve, then this is called a neuralgic pain. Example, trigeminal neuralgia. So it's a neuralgic pain. Why? Because the distribution of the pain is limited within the area supplied by the trigeminal nerve. Meralgia paresthetica. It's a neuralgic pain because pain is distributed along the distribution of the lateral cutaneous nerve, lateral cutaneous nerve. But suppose diabetic peripheral neuropathy. Do we call it diabetic peripheral neuralgic pain? No, because here it is not involving. Sometimes diabetes can also call a mononeuropathy. If it is a mononeuropathy, that can call a neuralgic pain. But otherwise, diabetes peripheral neuralgia, neuropathic pain that is involving the small diameter fibers, that is not a distributed along particular nerve. So neuralgic pain, you understand, is a subtype of the neuropathic pain. How the pain is distributed along the particular nerve. And neuritis means it is inflammation. Sometimes the inflammation of a single nerve, say for example, radiculitis, nerve root is getting inflamed because of the leaked nucleus pulposus in the prolapse disc. That is a kind of neuritis. Sometimes there is autonomic neuritis, forming the peripheral neuropathy, small diameter fibers neuropathy. Sometimes the inflammation is there. So inflammation, if it is there, it is called neuritis. And the drugs, Again, we'll be discussing more in the pharmacological class, pharmacotherapy. So a nociceptive pain is relieved by analgesics. Analgesic means either opioid or non-opioid. In the non-opioid, we are having the NSAIDs and paracetamols. COX-2 inhibitors is another class. We're close to the NSAIDs. So these are the drugs, analgesic drugs, useful for the nociceptive pain. But for the neuropathic pain, your analgesics has very minimal role. I should not say no role, but has very minimal role. Suppose somebody has trigeminal neuralgia. Will you prescribe morphine or tramadol? Will it work? Answer is no. Sometimes in some kind of neuropathic pain, sometimes the opioids have some role, particularly that we can discuss in the pharmacological classes. But just as a rule, you have to remember that the nociceptive pain, it is an analgesics. Neuropathic pain is at the co-analgesics. Co-analgesic means the adjuvant drugs or co-analgesics. So normally they are meant for the other like antidepressants. As I told you, antidepressant is smaller dose. Some antidepressant, particularly TCA and the SNRI group, they can be very good drug to relieve pain. This is called co-analgesics. Same way, anticonvulsants like carbamazepine in trigeminal neuralgia, then your gabapentin, pregabalin, all these are the anticonvulsants very frequently used in neuropathic pain. Apart from them, there are a few other co-analgesic drugs which are used. So they are not themselves are in the class of the analgesics. They are meant for the different, but ultimately this has been seen that it is very effective in the neuropathic pain, and they are called as an adjuvant drug. So nociceptive pain and neuropathic pain. And a third kind of pain also has been recently defined by International Association of Study of Pain. What is that? That is your nociplastic pain. So what is nociplastic pain? So nociplastic pain initially was, in a subtype of the neuropathic pain. It is basically a dysfunction of the nerve. So there is no non-neural tissue damage. There is no neural tissue damage, but still there is a dysfunction of the neural tissue. That is your nociplastic. Say, for example, migraine. Will you find any damage to the non-neural or neural tissue? Answer is no. Fibromyalgia. Will you find anything, the neural or non-neural tissue damage? Answer is no. But still, they are having pain because of the changes in the nerve. So this is the dysfunction of the nerve. So they are in the third type of pain, that is your nociplastic pain. So broadly, earlier the nociplastic pain was in the a subtype of the neuropathic pain, but nowadays nociplastic pain is a separate kind. Most of the books still do not mention about the nociplastic pain, but very soon it will be coming in the standard textbooks as well. So nociceptive pain, neuropathic pain, and nociplastic pain. Nociplastic pain means a kind of pain which is because of the dysfunction of the nerve. Damage of the nerve is your neuropathic pain. Dysfunction of the nerve is your nociplastic pain. Okay, so now another very important part. So last part. What is the time now? Another 10-15 minutes time I'll be taking. So the why there is neuropathic pain means what are the different dysfunctions? So they can be, I'll be not be going into the detail of that. But this maybe if I'm getting some more time, I might be discussing a little bit. I'll be just touching some of the points. So first of all, we should be remembering that our nerve is ever changing, and this nerve which is ever changing means earlier it was told that okay, once we are adult, our nerve do not change, but this concept has changed. Even if you're adult till our death, based on the peripheral inputs, our nerves are going on just changing, and this is called, what is this called? Is your neural plasticity. That means our nerves are changing continuously based on the inputs what it is getting. Like suppose, very simple example is, suppose somebody is having a blind. If a blind person's brain is opened and is examined, it's to be seen the visual cortex level has been getting atrophied, and the auditory, the tactile areas are getting hypertrophied. So depending on how it is used, our brain, our whole nervous system is going to get changed, and this is neural plasticity. Example of neural plasticity: Suppose, the cricket player, somebody is missing a catch. What will be commenting? Go and practice. So practice means you are giving the inputs, and gradually, your nervous system will be changing in such a way that that person will be more skillful. So this is neural plasticity. So neural plasticity is a change, but this change or adaptation is mostly because of our good, but sometimes it can do bad as well. So pain, the sensitization is a kind of maladaptation or a kind of the sensitization is a kind of neural plasticity. So again, neural plasticity, sometimes it comes as a question. What is neural plasticity, and what is sensitization? What kind of the changes? So it's basically it's also called a maladaptation. So the changes in the central and the peripheral nervous system is also called the sensitization, and it is a type of neural plasticity. So very simple way, neural plasticity can be good, neural plasticity can be bad. It can be a good adaptation or it can be a maladaptation. So this bad changes, which is increasing our pain, is basically the sensitization. So sensitization can be broadly classified into the peripheral sensitization and the central sensitization. What exactly is the sensitization? This is the definition, but very simply to remember, the noxious stimuli is getting amplified. So in a healthy individual, if a small prick is producing a small amount of the pain, in a sensitized person, he'll be feeling a lot of pain. So this is because of the amplification. So this amplification is basically sensitization. So this sensitization is because of the changes in the peripheral nerve, because of the changes in the central nerve. The changes in the peripheral nervous system is called the peripheral sensitization. So these are the peripheral sensitization heading. So quickly go through that. Normally, which I start with the upregulation of the active nociceptors. Means the nociceptor populations, active nociceptor populations will be upregulated and more active nociceptors to generate action potentials. Next important part is sensitization of the primary afferent terminals. Means the threshold for generating the action potentials, for the conversion of the one kind of energy to the other kind of energy, the threshold of the stimuli will be reduced. That means small threshold can generate the action potentials of pain. Then these two is very important. This I'll be taking a little time to explain this to listen this carefully, because many times in the subsequent lectures I'll be talking this term. This is also called the deafferences and pain. So what is deafferences and pain? Is basically when the peripheral nerve is damaged, many times it can increase the pain. So as you know that the nerve cell is special than the other cell because it is having a cell body here. All the metabolic actions, generation of the different proteins are all carried out within the cell body, and it has actions, it has dendrites. Actions and dendrites are just for the propagation of the action potentials, but the metabolic actions are not taking place within the actions and dendrites. So now these actions and dendrites, when if you are cutting it, it might be regenerating depending on certain factors. So what are those factors? So if we are looking about, we'll be again talking about this when we're taking the class of the radio frequency and the cryoablation. Just remember that the nerves can be regenerated if its peripheral coverings are intact. If peripheral coverings are not intact, if it is separated, the nerve will not regenerate. If cell body is damaged, it will not regenerate. But if the actions and dendrites are cut, then it can regenerate provided its coverings are intact. So now, when they are regenerating, it is possible that this regeneration is not perfect. That means, suppose on the periphery, A beta fibers carrying touch, after the damage, they should be again going through the A beta fibers only. But it has seen that there is a crosstalk. Crosstalk because of this action sprouts and forms a collateral, and they makes connection with the other kind of fibers. That means A beta fibers is making connection with the A delta fibers. So what will happen? With touching, the touch is converted into pain, allodynia mechanism, right? So this is very important because of the damage. And second important part is suppose you are cutting. So what will happen? We all know that the action potentials are propagated through the sodium channels. What are sodium channels? All the ion channels are basically some proteins. If you remember, the cell membrane covering is your 2 layers of lipid, and in between there is a protein layer. This protein layer, some protein is specialized protein, a large protein which is peeping through lipid layer either above or below, and that specialized protein is a kind of ion channels through which the configuration of which ions will be matching, that ion can go in or go out. So the sodium channel is also a kind of protein, specialized protein. So now this specialized protein, where it is getting manufactured? Remember, all the proteins in the body are getting recycled. It is broken down into the peptides and amino acids, and again it is synthesized. This goes on in all our cells. So here also in the nerve cell, these proteins, the sodium channels, they are recycled. They are manufactured in the cell body, and then they are transferred to the axon and dendrites to the periphery. Now, if there is a damage, what will happen? These sodium channels cannot go beyond to the periphery. The cell body thinks my axons is of this much of length, so I need to manufacture this much of sodium channels, and they goes to the periphery, and now highway is blocked, so all the trucks are getting accumulated there. So they cannot go beyond that damaged part. So what will happen? There will be abnormal accumulation of the sodium channel at the damaged axons and dendrites, and that becomes the source of the ectopic signal generations. So the periphery, the damaged axons and the axons and dendrites, the axon potential spontaneous development of the pain without having any the electrical signals, or sorry, any mechanical or thermal or chemical signals. The axon potentials can generate spontaneously. So these two together is called the deafferences and pain. That means you have cut a nerve. Sometimes this cutting of the nerve or damaging of the nerve can be done intensively to reduce the pain. But in certain situations, this pain might be increased. So the area might be having numbness. The patient will be telling, my limb is numb, but from that numb area, pain is coming. Sometimes the doctors are unable to explain, okay, how it is happening. Because that area is numb, but from that area, pain is coming. How it is happening? So these are the two mechanisms. So from that nerve, axon potentials are generated, not from the periphery, but from the damaged part. And that axon potentials is sending the signals. This is very frequently also seen not just in the periphery. It is also seen in the spinal cord injury. Suppose somebody is having a complete spinal cord transections because of accident or transverse myelitis. The patient will be telling, okay, I'm feeling pain from my legs. So why? Because the axon potentials in that damaged part, they are the ectopic signals are generating, and that axon potentials is reaching to the brain, and we are feeling pain. So area is numb, but still the pain is coming from that particular area. And these are the mechanisms. One mechanism is your ectopic signal generations. Sodium channel is abnormally accumulated there. And second is sprouting and crosstalk. So remember these two mechanisms. In many future classes, I'll be talking about this. And there are two other mechanisms, the peripheral sensitization. I'm just covering because time is very limited. Central sensitization, these are the different central sensitization areas. If you have any particular questions in the next class, we might be covering it. Today it is if you are having any questions, I'll be taking that at the end. So what happens in sensitization? Sensitization means, as I told at the beginning, that axon potentials which is generated at the periphery to develop certain amount of the pain amount is increased, amplified. That is your sensitization. It is just opposite to that of the modulation. Modulation is axon potentials should generate this amount of the pain, but the patient is feeling this amount of pain. Reduction. And this is physiological, but this sensitization is pathological. So because of the sensitization, pain intensity is increasing, pain area is increasing. Okay. So this is about the pain pathways, sensitization, modulations. Now you can ask me questions. I'm just stopping the sharing. And if you are having the questions, if you are interested, I might be talking about the central sensitization part also. And first, let us see what questions you are having. Because I can see many people started leaving, already 3 hours. So people started leaving, but still I'm here. I will be answering your questions. Hello. Kanchan, are you there? Can you tell me, tell me the questions what is there in the chat box also?
I think there was one question, sir, from the migraine, which is already being answered by Chinmay boss. Okay, sir. Dr. Anant wants to know, how do you treat pain from ectopic production?
Ectopic production.
I think he wants to talk. He wants to know about those ectopic action potentials. What we were just
As
talking.
I told you, at the damaged, when axons and dendrites, the sodium channels are proteins. They are continuously recycled. So this recycling, the generation of the new sodium channels, new proteins, all of this taking place within the cell body, and then they are going to the axons and dendrites to the periphery. If there is a damage, then these sodium channels will be getting accumulated at the damaged end, and that abnormal accumulation of the sodium channels is the reason why the ectopic signals will be generated spontaneously at that damaged part. I told you, if there is a peripheral damage, if there is a spinal cord injury, all these ectopic signals can generate spontaneously.
Sir, Dr. Narendra wants to know how pain is amplified. And Dr. Manish also wants to know the same thing.
Amplification, I already told you one of the mechanisms about how they man. Okay, let me just cover the remaining part, because I was thinking. Okay, so amplification is there are several mechanisms. One of them already told in the peripheral sensitization. You see, in the peripheral sensitization, what is happening? There is upregulation of the nociceptors. Second is, there is reduction of the threshold. So the small stimuli, which is going to produce small amount of the pain, because of this reduction of the threshold, now they are creating greater amount of the pain. But more, there are certain mechanisms, the central sensitization, which will be telling you regarding the amplification part. So one of the amplification part also can be understood by the descending inhibitory pathway. Descending inhibitory pathway, loss of descending inhibitory pathway is also a part of central sensitization. So in the central sensitization, first part is your central reorganization. So what is central reorganization? Central reorganization has three important components. One component is your loss or dysfunction of the descending inhibitory pathway. I already told you the natural inhibition by the descending inhibitory pathway is lost. So the small stimuli is going to more painful because of the inhibition has lost. This is number one. Number two is in the central reorganization part is that there will be certain, when the nerve are entering into the dorsal horn, and the second order neuron is taking the signals. So sometimes what happens, the interneurons are connected and send this signal to the above segment, sending the signal to the below segment, sending the signal to the other side. So what will happen, the initially pain which was located, now it will be diffuse. And it has been seen also in the animal experiment. So in the animal experiment, what was done, some of the nerve root was tied, and initially it was seen that in these animals, there was pain along that particular domain. But if the knot is not released, then gradually seen the pain is gradually spreading to the adjacent part, even to the opposite side, because of this interneurons is sending signal to the other side. So this is the second component of the central reorganization. The third component of the central reorganization is what happens here. The first order neuron, when entering into the dorsal horn, the second order neuron is starting. The second order neuron, there is the rex lamina. If you're remembering the rex lamina, so there is superficial lamina, deeper lamina from up to lamina 10, which is around the central canal. The superficial lamina, the small fibers ends, deeper lamina, the large fiber ends. That means starch fibers goes to the deeper lamina, pain fibers goes to the superficial lamina, and there is no connection in between. But in sensitization, what happens? The deeper lamina fibers basically sprouts, makes connections to the superficial lamina. So what will happen? The touch fibers which was coming, now it is converted into pain because they are making connections with the superficial lamina into the central lamina. The superficial lamina and the deeper lamina. So these three components together is called central reorganization. So central reorganization means one is dysfunction of the descending inhibitory pathway. Second is interneurons connecting the different parts, different sides, different segments by the interneurons, which is called the second component. And third component is your the superficial lamina, rex lamina, and deeper lamina interconnects because of the sprouting of the deeper lamina fibers. So this together is the central reorganization. So this is one of the explanation of the amplification of the pain. Second important amplification is second, let me talk one by one. So your questions will be getting it when you'll be covering all of the things. So next is your wind-up phenomenon. What is wind-up phenomenon? It is also called the summations. That means if the action potentials are generated in quick successions, they might be summed up and they might be having a bigger, stronger action potentials. That means small amount of the signals, they'll be clubbed together to having a stronger signals creating a larger peak. Next is your NMD receptor. NMD receptor upregulation. What is it? So NMD receptors are basically the calcium channel, but normal NMD receptors remains in a dormant state. They are not allowing the calcium to enter inside the nerve because there is a magnesium ion is sitting in the mouth of the NMD receptor, just like a cork in a bottle. So it is not allowing the magnesium ion is not allowing the sodium ion to go inside. But if when the activated NMD receptor means the magnesium is not there. So how it happens? There is another called AMPA receptors. AMPA. So AMPA receptors will be sending signal to dislodge the magnesium, and then the calcium can go inside. If the calcium goes inside, what will happen? This calcium will be binding with the neurotransmitter field vesicles, mostly the excitatory vesicles, neurotransmitter field vesicles. So the more excited neurotransmitter vesicles will be released, and there will be again amplification of the pain. The ectopic signal is also a kind of amplifications. Depression of the inhibitory synapses. That means, as I told in the pain modulation, that there is segmental inhibitions. So here, that inhibitory synapses are getting suppressed by the sensitization, and activation of the wide dynamic range cells. Wide dynamic range cell means there are certain second order neurons which is a non-specific. Means there are certain second order neuron which is for pain, certain second order neuron which is for touch, certain for the temperature. But here, wide dynamic range cells can transmit all the different kind of factors. So now these wide dynamic range cells now is recruited in the pain pathway. That means initially they was transmitting all the different kinds of signals. Now they're telling no, I'll not transmit touch, I'll not transmit temperature, I'll be transmitting only pain. So these wide dynamic range cells are activated and recruited in the pain pathway. So these are all different central reorganization. Central reorganization, what are the effects? Effect is amplification of the pain. So you can understand what are the mechanisms of the amplifications. Amplification, one is your descending inhibitory pathway, one is your the wind-up phenomenon, one is your upregulation of the NMD receptors activities, one is your depression of the inhibitory synapses. So all together, there are a lot of mechanisms for the pain to be getting amplified. Second important area, is your area of the pain is increasing. Area of the pain is how it is increasing. As I already mentioned, the interneurons are there, which are activated, and they are transmitting signal. Suppose the signal was reaching at the dorsal horn at the level of the L4. Now from there, the signal is transmitted to the L5. From there, signal is transmitted to the L3. And to the other side. It was in the right side. Now it is on the left side. So that is how the area of the pain is also increasing. The duration of pain is also increasing. How? Because there are a lot of changes in the central nervous system, and some of the changes are very difficult to reverse it back, and that is the reason why the neuropathic pain duration is long-term duration. If you are using a antidepressants, don't prescribe it for the 1 week or 2 week or 3 week. It should be prescribed for several months. So this treatment, the duration of pain is for the long term. Decreased tolerability of the pain already discussed because of the modulation system is exhausted. The psychological problems, gradually when the pain will be there, the long-term pain will be there, the psychological changes will be there, and pain became unresponsive to the conventional analgesics. So analgesics are not enough to take care of this kind of pain. You need to add analgesics or adjuvant drugs. Right? I hope the question has been answered. So is there any relation between the sensitization and nociplastic pain? Of course, as I told you, that sensitization, sometimes, many times, there is no anatomical changes, but dysfunction. So whatever the sensitization is, I told you, some sensitization is anatomical changes, but majority of the sensitization is basically the dysfunction, physiological dysfunction. So basically the nociplastic pain, all these dysfunctions are there. Like nociplastic as I given you the example of the osteoarthritis knee. Osteoarthritis knee is nowadays proved that it is not a pure nociceptive pain. There is some, the neuropathic component, and or nowadays this part is also called the nociplastic component.
হুজুরের কাহিনী বাইরে এসেছে।
Okay, any other questions from anybody?
প্রথম বউয়ের বাড়িতে ছিল এতদিন।
Hello. Any more question in the chat box, Kanchan?
No, sir. Something about antipsychotics, but I think we can discuss all your questions which you have written and related to pharmacology in our pharmacology class. So do not worry. Just remember your questions and do ask us when we will be taking your class on drugs. Right?
Right.
I think no more questions, sir.
Hello.
Right.
Okay.
Let us say good night for today. It is already, 9 to 9, and as I told already that next day there will be Kahoot questions also. All of you should be downloading Kahoot on your mobile. You will be seeing questions on the laptop, and your mobile will be an answer pad through which you will be answering.
And
also, please join in time, 10 minutes or 5 minutes before the 6 p.m.
Hello, excuse me.
Yes, Dr. Yeya, tell me.
Please, how we can download Kahoot?
We have already shared, I think, the steps in the Telegram channel. So do not worry, we'll be sharing it again if you have not gone through it. And as sir said, please be on time because 6 o'clock sharp, we will be starting Kahoot. Okay. And I will be calculating all the scores of all the participants, and whosoever is going to score the highest top 3, we have a very big surprise for, I think, all those winners, right? And so certificate of appreciation will also be given from the Dardia side. So please do attend Kahoot next time and be on time. And if you have any questions, you can ask. I think in the next class already sir is having that vocal nodule. So if he talks, keeps on talking, he develops that cough. Right, sir? So can we take up the questions in the next class? Yes.
Ma'am, how to join Telegram, ma'am?
Have you
Please,
received
can you
a mail from Dr. Devjyoti?
Yes, ma'am.
You have received a mail?
Yes, ma'am.
So there will be a link in that mail. Okay, you need to click on the Telegram link and you will be directly in.
Okay, ma'am. Thank you.
Okay. So all of I think some of you, if you have not received the mail from Devjyoti boss, you please write us at info@dardia.com and do mail us your email ID so that we will be sending you all the links, everything, steps to download Kahoot, all those things. And about this today's study material, I will be uploading it in Telegram tomorrow morning. So go through the study material, and like after reading the study material, even if you like, if you have some questions, you can always ask us. Feel free to ask us. There is basically an email ID which is being shared by Dr. Devjyoti in Telegram channel. Please put up all your questions. You write all your questions and just send us. We will always be there to help you out.
Ma'am, how can we see the recorded lectures?
We will be sending you a link. We will be sending you a link with a password. Okay, so you need to press on that link. You need to type that password. Okay, and then you will be able to listen to the recording, and that recording is going to be available for a week, right? Because we need to delete it so that our iCloud is free and we can just record
You can upload only one lecture so that by next day when we'll be recording the next lecture, this lecture will be automatically deleted. So whatever number of times you wish to see, you can check any number of times till the next class.
Okay, sir. Thank you so much, sir. Thank you so much.
Okay, thank you everyone. Sir, can we just say bye? Sir? Sir?
Yes. Bye and good night for today.
Okay. So good night, everyone.
Yes.
See you.
Am I not audible?
Suddenly you were not, but now you're very much audible.
Okay. So good night, everybody.
So you can again ask any question from sir in the next class. And if you have any doubt, he is always there to clear your queries. Okay. So good night, everyone. See you next time. Be on time because 6 o'clock sharp, we will be starting Kahoot. Okay. Take care. Bye-bye.